part of the talk is on inhalation agents by Dr. Sanish PJ, who is a senior consultant at Anandapuri Hospital at Thiruvananthapuram. Dr. Sanish, I welcome you to this meeting.
Thank you.
A very important short case discussion by Dr. Avani Sanjeevan, who is from Government Medical College, Kottayam. Dr. Avani, welcome. And this case discussion will be examined by two young academicians, Dr. Sanji KS, who is additional professor and HOD Government Medical College, Kottayam, and Dr. Ashish Karthik, who is the associate professor, Government Medical College, Thrissur. And this academic program is coordinated by Dr. Venkatagiri KM, President-elect, ISA National, Dr. Rajesh MC, who is the senior consultant, then the scientific chairman, ISA Kerala State Chapter, and Dr. Vijesh Venugopal, GC member, ISA Kerala State Chapter. I welcome Dr. Sandhi, Dr. Ashish Karthik, Dr. Rajesh MC, Dr. Vijesh Venugopal, and Dr. Venkatagiri, and all my dear postgraduate students to this meeting, and request for your active participation. Dr. Venkatagiri, please, your opening remarks. Dr. Giri?
Yeah. Good evening, President Nazar, Secretary, and friends. I'm happy that I think it is echoing. Yeah. And I'm happy that this program is going well since the beginning, and it is appreciated by one and all from all over India that it's a consistently we are having this program. And with the different the case discussion, then Oski and the last week's Oski was really good, and there was a lot of appreciation not only from PGs but from others also, telling that it was beneficial from practicing anesthesia also. So all the best, Team Kerala, and wish to have more such programs for the benefit of both the PGs and anesthetists. Over to you, President, and I thank all the faculties who have joined and who are joining in future also for these academic programs. My Guru Madhusudan is there, special thanks to him. Thank you.
Thank you, Dr. Giri. Now over to the webinar coordinators, Dr. Rajesh and Dr. Vijesh Venugopal, please continue the academic proceedings. Dr. Rajesh and Dr. Vijesh, please take over.
Thank you, Dr. Nasser. We don't waste any time. And we have two long sessions. The first one was will be delivered by Dr. Madhusudan Upadhyaya regarding uptake and distribution of inhalational agent, and the second session by Dr. Sanish on individual anesthetic agents. And he will be discussing about the newer generation of anesthetic agents, as well as a glimpse about the past agents also. So over to Madhusudan sir. Sir is former professor and HOD of KMC Mangalore, a well-known academician and a regular examiner for postgraduate examinations all over India, and is a regular speaker for all academic events of ISA Kerala and South India, as well as for the national conferences. So over to Professor Madhusudan Upadhyaya and Dr. Sanish. Madhusudan sir, please.
Good evening, everybody. I'm trying to share the screen.
Please share, sir.
Is it seen now?
No, sir.
Now?
No, it's not coming.
Now? Anybody from the technical team?
No, me only. I can help.
No, why is it not coming through? Share screen.
You are the co-host, you'll be able to share, sir.
Yeah.
That screen share option is there, no? Green button.
Yeah, I know, I'm trying.
Yeah, now it's coming, sir,
Okay.
coming. Yeah.
Okay.
Uptake and distribution.
First of all, my heartfelt thanks to ISA Kerala for planning such a wonderful program week after week. I know that webinars, there is a little less difficulty as is perceived by everyone because you don't have to host the speakers, and then you don't have to organize other than the technical aspects. But getting the people to do the programs, I think, is one of the most difficult things. That too at odd times on a weekend. Yeah, thank you very much. And whenever I say Kerala has asked me to do something, I could never say no. Therefore, here I am again. But Rajesh has given me a very difficult task of talking about uptake and distribution of inhalational anesthetics. Basically, I love the clinical topics. And when it comes to the physiology and pharmacology, the basic sciences, I'm at a loss. But still, I will try my best to communicate with the postgraduates. If the postgraduates in the audience, if you need to know something, you may stop me then, and we can discuss if you have any doubts in the middle. Otherwise, we'll have a discussion at the end of the topic. And actually, this will be followed by Dr. Sanish's talk. And Sanish was my student here, and then he was my colleague. And then I think I owe a lot of my academic activities to Sanish. And anyways, without wasting much of the time, let me start off with the uptake and distribution of inhaled anesthetics. Why this is important is there are numerous reasons why every anesthesiologist, practicing anesthesiologist, should know about the pharmacokinetics and dynamics of inhalational agents, inhaled anesthetics. Basically, because the anesthesia provided by the inhaled anesthetics is more predictable. The way we talk about TIVA, we also talk about VIMA nowadays, volatile induction and the maintenance of anesthesia. Because people believe that you have a lot of control over the uptake, and then at the time of reversal too, getting rid of the inhaled anesthetics from the tissues of anesthetized patient is much easier than the IV induction agents or IV maintenance. And also the inhalational induction, whatever agents we use can be monitored through the respiratory gas monitor. You don't need sophisticated equipments to know the blood levels of induction agents or maintenance agents like with TIVA. Therefore, this becomes more imperative, and mostly from time immemorial, anesthesia began with the inhalational agents, and the inhalational agents are here to stay. Whatever we talk about TIVA, the inhalational agents are here to stay. Therefore, it's better that everybody knows everything about the inhalational agents and how they behave inside the human body. Modern inhaled anesthetics are important pharmacologic tools for reversibly altering central nervous system functions. And they are taken up and eliminated through the alveolar blood exchange. And I think that is why blood gas exchange, and that is why, as I said, it becomes very predictable. Drug dosage can be monitored in expired alveolar gases, unlike with the IV induction agents. I just said that. And tissue-dependent metabolism is unnecessary for drug clearance. And most of the inhaled anesthetics, they are inhaled and exhaled as such. The metabolism which happens in the body is not to a large extent. It's very, very minimal. Therefore, even abnormally functioning organs will not hinder the kinetics and dynamics of inhalational agents to the extent the intravenous agents do. When we talk about the uptake and distribution, we follow the Mapleson model, which was advocated by Mapleson in the year 1973. And I will talk about that at the end of the talk. But please remember that Mapleson's model is something which we still use. We need to know a few of the biophysical properties of inhaled anesthetics. And they are partial pressures, hydrophobicity, and partition coefficients. And we'll talk about each one of them in a little detail in the coming slides. Partial pressures, we'll start with the partial pressures. Before that, every postgraduate should know this by heart, because anyway, Sanish is going to talk about all these individual inhalational agents in the next lecture. But still, when you are asked about the pharmacology of inhalational agents, obviously, one of the first questions in the first paper would be, short notes at least will be on an individual agent. And or maybe you will be asked to compare and contrast two of the inhalational agents. When it comes to that, we have to start with the chemical structure. It's imperative that you know the chemical structure of each of the inhaled anesthetic, and then all the other properties. I'm not going to talk about every bit of it, but you need to know about the boiling point, density, vapor pressures, and oil gas partition coefficient, and the blood gas partition coefficient. Throughout the lecture, I will be talking about blood gas partition coefficient, because that is what dictates how an inhalational agent works within us. And higher the number of blood gas partition coefficient, the absorption into the blood is higher, and therefore the achievement of alveolar concentration of agent is much slower. Therefore, the drug offtake and reversal at the end of the procedure becomes a little tougher for agents which have higher blood gas partition coefficient. Therefore, what scores over here is desflurane, which has the least of the blood gas partition coefficient. And I'm not going to talk about the nitrous oxide, because nitrous oxide, as you are aware, obviously as a sole agent, you cannot be anesthetizing. You will use it as a carrier gas. You will use it as the first gas when for the second gas effect, but it will not be used as a sole anesthetic, just because the MAC of it is highly, the 104 is highly impossible to achieve in a controlled environment. And then MAC immobility is something which we all know. Basically, anybody who walks into anesthesia on the first day is taught about this. And you should also know what is the percentage of the partial pressures. What is the percentage of the atmospheric pressure? Atmospheric pressures, you should remember, it is 760 millimeters of mercury. We need them throughout the inhalational agent, the uptake and distribution when we talk about. MAC awake obviously is 1/3 of the MAC immobility, and throughout it remains the same, and it is worthwhile remembering. From this chart for this lecture, I would request you to remember only the blood gas partition coefficient at normal body temperature and 1 atmospheric pressure. It's also worthwhile knowing the blood gas partition coefficient for 1 atmospheric pressure absolute. It's always better to, we are all on the coastal side, therefore we will not have any issues with managing the partial pressures and induction with inhalational agents. But if you are at a higher altitude, it becomes an issue. Therefore, it's always better to convert it into atmospheric pressure absolute. All right. But please know this, because you cannot pass your exams without knowing the physical properties of inhalational agents. What is partial pressure? Partial pressure is the portion of total pressure contributed by one component of a gas mixture, where each component contributes pressure in direct proportion to its molar fraction. And the partial pressure of an anesthetic gas is a measure of thermodynamic activity of the gas, and it determines its pharmacologic effect. To give you an example, if you have 1.5% of isoflurane in air, air effectively contains 21% oxygen and 79% nitrogen at 1 atmospheric pressures. That is, as I said, 760 millimeters of mercury. It is a mixture of oxygen at 157.2 millimeters of mercury, that is 21% of 760, and 591.4 millimeters of mercury, that is the partial pressure of nitrogen, which amounts to 79% of 760, and isoflurane at 11.4 millimeters of mercury. That will be 1.5% of isoflurane. Wherever you go through when you talk about the uptake and distribution, this calculation you should remember. The partial pressure of an inhalational agent, whether you talk about the second gas effect or concentration effect, you should know about the partial pressure exerted by each component of the total fresh gas flow which goes out. It also comes to your rescue when you talk about or practice low flow anesthesia, when your fresh gas flows are as low as 500 to 600 millimeters of mercury. Though it is said that you need to have a respiratory gas monitor, even without the respiratory gas monitor, you should be able to calculate how much of sevoflurane or inhalational agent is going in along with the carrier gases. All right. Hydrophobicity, when you talk about hydrophobicity, it also means that the agent's lipophilicity. And if the agent is hydrophobic, and it also means that it is lipophilic. What is hydrophobicity? It's a molecular property of certain chemicals, including most general anesthetics, that do not readily form hydrogen bonds and therefore display low water solubility. As I said, the compounds are also usually lipophilic. And when you talk about the lipophilicity, it means that the solubility in low polarity solvents such as oils or the drugs, they dissolve much more if they are lipophilic. They dissolve much more with in the fat. Therefore, when you talk about the metabolism or the reversal of inhalational agents, a lipophilic agent will take longer time to get out of the fat. Therefore, even if you achieve MAC awake on the respiratory gas monitor, the patient might still be releasing a little bit of inhalational agents from the fat, and but it may not add up to much to keep the patient sedated or anesthetized, but still you should remember that they keep coming out. Move on to the partition coefficients. It's usually partition coefficients are represented with lambda. A partition coefficient is the ratio of two solute concentrations at equilibrium, that is at equal partial pressures, in two separate but adjacent solvents or compartments, such that the solute moves freely between the compartments. I know that for a postgraduate, it's a little difficult to remember these definitions, but since you are a postgraduate, you are expected to, because we all went through the definition of shock when we did the pathology. And obviously it was not to our liking to keep it learned by hearted and then remember it. Similarly, you have to remember these terminologies and their definitions. A partition coefficient is the ratio of two solute concentrations at equilibrium, that is at equal partial pressures, in two separate but adjacent solvents or compartments, such that the solute moves freely between the compartments. What does it look like? We'll take an example of isoflurane. Most of what I speak today has been picked from Miller, because Miller has dealt with this beautifully. The chapter on uptake and distribution is beautifully dealt by Miller, and therefore I've also taken a lot of it from Miller. This image too is from Miller's. On the left, I have taken an example, or Miller has taken an example of isoflurane, which has lambda blood gas partition coefficient of 1.4 and brain blood partition coefficient of 2.2. What exactly does it mean to you? On the left half, what you see is alveolar gas to blood to brain. This is in equilibrium. What does it mean is the at equilibrium, the isoflurane partial pressure in all compartments, like in alveolar gas, to blood. Alveolar gas will have, say, 1 amount of vapors, and blood will have 1.4 amount of vapors. All right, it is 1.4 times the vapors, and then the brain at equilibrium will have 2.2 times the vapors of the blood concentration or the partial pressures. Therefore, if you see on the right, the blood to alveoli basically is 1.4 times, right? This is 1, but alveoli, when it is in equilibration with the alveoli, it is 1.4. And as I said, the brain will have 2.2 folds or 2.2 times of what the blood carries, or the partial pressure of isoflurane in the blood. And that is what? It is 2 plus 2, 2.2 times. Similarly, it is 3.1 times the alveolar gas. When you look at the partial pressures of the same isoflurane, it will be 3.1 times of the alveoli in the brain, or 2.2 times of the blood in the brain. Right? Am I clear? That much about the partition coefficient and introduction into partition coefficients. We'll talk about the uptake and distribution of inhaled anesthetics. Generally, how does it happen? You have a common gas outlet, and the common gas outlet will allow whatever the dial settings you have set, and whatever fresh gas flows you have set. That will be the number of vapors carried out into the common gas outlet. Okay, and from there it's taken up by the cardiac output, which reaches the pulmonary circulation. It's picked up by the pulmonary blood flow, and from there it gets into different body tissues. The arrows here, when you talk about the pulmonary blood flow, it takes the anesthetic vapors or anesthetic gases, the arterial blood. It allows, when you look at the arrows are of the same size, proportionate to the vapors reaching the different groups of tissues. The vessel-rich group, we talk about, basically we want the inhaled anesthetics to act on the brain, and brain is a part of the vessel-rich group. Then it also reaches the muscles a little later, and then the fat, which has the least of the blood supply, reaches the last. Therefore, equilibration, if at all it has to happen, it happens with the VRG first, vessel-rich group first, and then with the muscles, and then finally with the fat. And if there is the systemic shunt does not contribute much to the vapors missing any of the tissues, and and pulmonary shunt too, which does not pick up any of the vessels. It does not go through the pulmonary blood flow. It directly reaches the arterial side, and both actually nullify each other. Therefore, it doesn't clinically become very significant. The fresh gas flows, which come out of the vaporizer and the flow meters, they reach the circuit. The circuit is the partial pressure in the circuits is one of the factors which determines how much of the inhalational agents reach the alveoli. And the alveoli, the coronary circulation, the cardiac output which reaches the pulmonary blood flow picks up the inhalational agents depending on the pressure gradients. Again, it's dictated by so many other factors. We'll look at them later, but the alveolar partial pressures, and then once it is picked up by the pulmonary blood flow, it moves on, and sequentially it reaches the vessel rich groups and muscles and the fat. And as I said, the arrows demarcate the amount of inhalational agents and the blood supply which reach each of this. And towards the end, I will give you in a nutshell how much reaches which group. And the reverse is also true when the inhalational agents will leave the vessel rich group first after the cessation of inhalational agents supplied to the patient or the patient's alveoli or the circuit, and muscles next, and fat, as I said, the last. And whatever happens once the tissue saturation happens or equilibration happens, it will reach back into the mixed venous blood, and then it goes back into the reverse happens, goes to the pulmonary blood flow, and the alveoli pick up the remaining gases and then goes back into the circuit, and the excess gases will go into the scavenging system, or they're also called the waste. Rate of wash in and wash out of inhalational agents is something I expect all the postgraduates to go through that, all the formulae given in the Miller. I'm not going to talk about those 7-8 formula which Miller gives. I sincerely wonder whether they are needed for you in your exams, but to build upon your knowledge, obviously, you need. Rate of wash-in of the circuit is something which is needed. That's an equilibration between the vaporizer and the circuit. You need it for a few things in VIMA, or if you are planning volatile induction. When you try to do the priming of the circuit, it surely is one of the factors to note when you try. I mean, you have to look at the wash-in of the circuit. And as I said, the fresh gas flows and goes through along with the the vapors from the vaporizer, they reach the circuit. The size of the circuit is surely important when you talk about the priming. And when you talk about the closed system, earlier when we were postgraduates, the closed system, so the earlier days, few years ago, we used to have very bulky soda lime canisters and very compliant tubings, and then it used to up till the FRC, which contributes to the circuit, which has to be filled first. It used to be something like 10 to 15 liters of capacity, but now anyway you have very compact soda lime canisters, and then you have tubings which don't expand to 30% like it was allowed earlier. Therefore, the capacity or the circuit, the volume has come down to 3 to 5 liters. Therefore, filling 3 to 5 liters is not so difficult vis-a-vis filling up 15 liters as earlier, right? That's important. Once the partial pressures of the inhalational agents in the circuit goes up, as with the priming, it generally helps to hasten the induction with the inhalational agents. I just said this. And what you should also remember is the time constant. When you talk about the time constant, it's basically the old gas in the breathing circuit should drop by about 63%. And after 4 minutes, less than 2% of the old gas remains. That should be the fresh gas flows when you start off. All right. The half-life of the process, the time for halving the vaporizer circuit concentration difference is about 0.0693 into the time constant. A time constant of 1, that's about 2 minutes for vessel-rich groups, and 4 to 6 minutes, that is 2 to 3 time constants, the vessel-rich group should be fully saturated with whatever inhalational agents you have tried. And this is the wash-in of the breathing circuit, and it depends on the fresh gas flows. And the curve basically tells you when the fresh gas flow is 3 liters and 6 liters and then 12 liters. By increasing the fresh gas flows, obviously the uptake goes up. The partial pressures in the circuit to delivery, obviously it peaks much earlier than with 6 liters or 3 liters. 3 liters basically is quite inadequate, and believing that your breathing circuit has 6 liters of gas, and the cross lines, the cross marks, basically they mean that the sorry, indicates the time constants basically at various times, and at time constants under different fresh gas flows. And with the fresh gas flow of 3 liters per minute, the time constant is about 2 minutes for the fresh gas flow or the vapors to occupy 63% of the space. And then with 6 liters, it is halved to 1 minute, and with 12 liters obviously is halved further, and it becomes half a minute. Therefore, the adequately ventilated patients with the breathing circuit of 6 liters and 6 liters of fresh gas flows, we should achieve in 1 minute. Okay. What is the clinical relevance? I just talked about the priming of the anesthetic circuit, and especially when you are planning a single breath induction, you want to prime to max and then try to induce the patient with the single breath induction technique. And whenever the patient vaporizer settings are altered, the speed at which the new settings influence the wash in or wash out of the circuit depend on the fresh gas flows. Especially so when you are practicing low flow anesthetic, or even with the high flow anesthetics. But with high flow anesthetics, you can change the effect, the changes a little faster. But with low flows, when your fresh gas flow is as low as 500 or 600 ml, to effect the changes, it takes a little longer time. And therefore, you have to keep a constant watch on the exhaled MAC or exhaled sevoflurane concentration, whatever inhalational agent you use, and play around with the dial concentration depending on what you want to achieve. Okay, the clinical relevance of wash-in, as I said, the priming, right? Then talk about the equilibration between the circuit and the pulmonary airspace. It's in rapid equilibrium with circulating blood and highly perfused tissues, including the target tissues in the CNS. As I said in the beginning, ultimately you want to achieve the same concentration which is required to suppress the cerebral functions, and you need to achieve that in the CNS. And alveolar partial pressures can be measured. That's the advantage I talked about in the beginning. It can be measured in the exhaled and tidal gases. Okay. Alveolar uptake of anesthetic into pulmonary blood. Uptake is nothing but cardiac output, that's Q, into lambda of blood gas partition coefficient, multiplied by alveolar partial pressure minus mixed venous partial pressures. The uptake of an inhalational agent is a product of cardiac output and the blood gas partition coefficient and the difference between alveolar and mixed venous partial pressures of the inhalational agents. During an inhaled induction of anesthesia, the rate of increase of alveolar partial pressure is relative to circuit partial pressures in the circuit is governed by alveolar ventilation, cardiac output, and anesthetic solubility in the blood. That's what I said just now. The more soluble an anesthetic is in blood, that is the higher the lambda, blood gas lambda, the more each volume of blood can take up the anesthetic from alveolar gases. When I talked about the properties of inhalational agents from that chart in the beginning, I had talked about this. It's the same. And when the blood gas partition coefficient increases, the alveolar to circuit partial pressure ratio increases more slowly. Basically because more of the inhalational agents are taken away from the alveoli, and the pressure gradient between the alveoli and the blood goes up, but still the supply into the alveoli does not match up, then there will be kind of a deficiency, and you have to increase the dial concentration to get more in lesser time duration, more of vapors in the lesser duration of time. The other factors that affect the rate of rise of alveolar partial pressures are dead space. Dead space can be physiological dead space and then the dead space of the circuits. Pulmonary shunting, I just touched upon that, and it matches with the shunt in the periphery. It may not be clinically very significant, pulmonary shunting, and concentration and the second gas effects. For the postgraduates, all this can be short notes, and concentration and second gas effects surely is a short note question in paper 1. How does each one of this affect the anesthetic partial pressure, alveolar anesthetic partial pressure? You can go through these charts from again the graphs from the Miller, but it's again absolutely commonsensical. On the left, you have the controlled system, but it's an open circuit where the fresh gas flow is as high as 50 liters per minute. And on the right, the graph is a patient where there is a partial rebreathing circuit with a fresh gas flow of 6 liters per minute. We'll compare halothane, which is highly soluble in blood and has a higher blood gas solubility coefficient, and then sevoflurane, which is largely insoluble compared to halothane. It's not that it is not insoluble, but it's better compared to lesser compared to halothane. The comparison is when the minute ventilation is different. It's 2.5, 5, and 10 liters, and the line without serrations, without breaks, is when the fresh gas flow is the minute ventilation is 5 liters on both the graphs. And it's very easy to understand that when the fresh gas flows are very high like this, it's the patient or you can achieve the higher partial pressure gradient much earlier compared to when there is a partially rebreathing 6 liters per minute of fresh gas flows. Here the graph is vertically upwards, and here it slopes towards the right. And the rest of the things, they remain almost the normal. And halothane, the peak is achieved much slower with fresh gas flows, lower fresh gas flows, whereas with higher fresh gas flows, you can reach the concentration or partial pressures much faster. And at the end, when you stop the inhalational agents, the fall in the partial pressures is also, it takes its kind of mirror image of what happens in the beginning. In the beginning, it is achieved faster here. Similarly, with that kind of a fresh gas flow, it also falls faster. Whereas with the lower fresh gas flows, it achieves the partial pressures much slower, and it also goes down much slower. And obviously, as I said, the minute ventilation too has a role to play. With higher minute ventilation, obviously, you can achieve the levels much faster, the partial pressures much faster. With lower minute ventilation, it will be much slower. What is the effect of cardiac output on the rise of alveolar anesthetic partial pressures? Please remember that when the cardiac output is more, obviously, sorry, when the cardiac output is more, obviously the pulmonary circulation goes up. Therefore, the anesthetic gases or the vapors are picked up from the alveoli at a faster rate. Therefore, the alveolar partial pressures will not build up the way we expect it to. Therefore, when the cardiac output is lower, obviously it doesn't pick up that much of vapors. Therefore, you can achieve the partial pressures of inhalational agents in the alveoli. Alveolar partial pressures are achieved much faster. Here, desflurane and isoflurane is compared with cardiac output of 2.5 liters, 5 liters, and 10 liters. And the blue one is isoflurane, and green is desflurane. And as I said, it's exactly compared to the graph what you saw earlier. This is exactly the reverse. When the cardiac output is lower, 2.5 liters, the achievement of the partial pressures is much slower. When it is cardiac output is lower, the achievement of partial pressures is much faster. But when it increases to 5 liters, it takes the partial pressures achieved are much lower, and then further it is much lower when the cardiac output reaches 10 liters. And it's again, I have already explained why exactly does that happen. When this is with again the same as the previous graph, where the fresh gas flows are 50 liters per minute, and on the right you have fresh gas flows of 6 liters per minute, and again partially rebreathing circuits, and the rest of the conditions are the same. And the partial pressures are achieved slower because of lesser fresh gas flows. But the rest of the things, when you compare it with the left side, they remain the same. With lower cardiac output, it's higher, and the higher cardiac output, it is much lower partial pressures, alveolar partial pressures you can achieve. What is the effect of blood solubility on the rise of alveolar anesthetic partial pressures? Here, all the inhalational agents which are available to us are plotted. The graphs are plotted against each other. And obviously, as I said, the blood gas solubility lambda Bg is something which determines what levels it could reach. This is methoxyfluorine. I think it's not needed to talk about methoxyfluorine anywhere, but only thing why it is put up here is it's because it has a blood gas solubility coefficient of 11, which is the maximum when it comes to inhalational agents, historic or present. And then you have halothane. Halothane also has become mostly irrelevant, but still there will be centers where it is used. Therefore, we can still talk about halothane, and then you have isoflurane, and then 0.65 is sevoflurane, and 0.45 is desflurane. Therefore, the partial pressures achieved are much higher with desflurane vis-a-vis halothane. Halothane is absorbed by the circulation from the alveoli faster. The same reasons which I said earlier. Therefore, halothane is picked up much faster. Therefore, the peak levels will not be achieved in the alveoli that fast. And desflurane, you can achieve the partial pressures, increased partial pressures much faster. And because it's not picked up by the, picked up by the inhalational agents to that extent, picked up by the blood to that extent. Therefore, this remains higher. Then, and when you talk about the achievement of increased alveolar partial pressures, that means that if you can achieve faster, again, as I said, the uptake or the offtake is much faster, and therefore the patient can be induced better with that particular inhalational agent. Otherwise, for halothane, you have to have increased dial concentration to bring it up. Whereas with the sevoflurane or desflurane, you don't have to struggle that much, and the induction is much faster. And again, it's the same thing. You compare 50 liters of fresh gas flows per minute, and then with 6 liters per minute. I don't have to repeat the same thing. The offtake is a lot slower, and even at the time of cessation of the inhalational agents, the fall in the partial pressures is much faster with higher flow rates. And that is what you see when at the end of the case, when you really wash out the inhalational agents, you increase, even if you have practiced low flow anesthesia, you increase the fresh gas flows to say 6 to 8 liters of oxygen, or if you have the practice of keeping nitrous oxide during reversal and extubation, still increase the fresh gas flows so that you can wash out the inhalational agents from vessel-rich groups. And the same thing happens even there. When you increase it, there is sudden fall and gradual fall when it is only about 6 liters. Okay, second gas effect and the concentration effect, I thought I would give it a slip because it has been often talked about and and everybody knows about it. Shall I? I think it's oh, I have taken too much of time. But still, few lines about second gas effect. I will not describe that. Anyway, it will be available to you. The second gas effect occurs when a soluble first gas, such as nitrous oxide, is delivered in high inspired concentrations, and the alveolar capillary uptake of the first gas increases the alveolar concentration of the other gases present, accelerating their uptake. The whole idea is to make sure that nitrous oxide levels go up, and so that as a carrier gas, and then when 50% of the nitrous oxide is taken up, absorbed into the system, by the alveolar volume reduces by about 34%, 33.5% basically. And therefore, there will be concentration of the inhalational agent vapors, which have reached the alveoli by then. Therefore, what you should remember is the partial pressures or the pressure gradient is something very important for the inhalational agent to be absorbed by the blood, taken off by the pulmonary circulation. Therefore, whole idea is to when nitrous oxide is taken in, the concentration of inhalational agent, CO or DES or whatever, the pressure goes up, and therefore that the chances that is absorbed into the system is much higher. Therefore, for VMA, this is a wonderful possibility. The magnitude of the second gas effect may be greater when the effect on arterial blood partial pressures is measured due to the effect of inhomogeneity of ventilation and blood flow ratios on the distribution of perfusion-driven nitrous oxide uptake throughout the lung. And the modeling of ventilation perfusion inhomogeneity confirmed that the second gas effect is greater in blood than it is in the expired gas. And its magnitude increases in blood, but decreases in expired gas as the degree of ventilation perfusion mismatch increases. The MAC calculations, usually based on end-tidal anesthetic concentration measurements, may well underestimate the depth of anesthesia when nitrous oxide is supplemented with a volatile agent. But newer respiratory gas monitors, which come with our multi-para monitors, generally take into consideration both the agents, therefore exhaled. Therefore, it may not be that much of that different from actually what it is in the lungs of the patient, but still it can underestimate because of nitrous oxide, more nitrous oxide gets in because of the second gas effect. This is the concentration effect, and this is way back in 1964 when Epstein plotted this graph with the 10% of nitrous oxide and 70% of nitrous oxide along with inhalational agents. And obviously with 70% of nitrous oxide, the FA by FI is much higher, achieved is much higher compared to 10% nitrous oxide and the inhalational agents. Similarly, when you use 0.5% halothane in 70% nitrous oxide, the FA by FI achieved is, that's alveolar to inspired, is much higher compared to 0.5% halothane in 10% nitrous oxide. Obviously, what the graph plotted wants to teach you is that 70% nitrous oxide can allow you to achieve much higher FA by FI, and the induction will be much faster. That's relevant even now when you try to talk about this is the same thing again. I said I will not talk about concentration and second gas effect. I think I'm stuck with that. The concentration effect is 65% of nitrous oxide there produces a more rapid rise in FA by FI ratio of nitrous oxide than the administration of 5%. And similarly, the second gas effect is FA by FI ratio for 4% desflurane rises more rapidly when given with 65% nitrous oxide than when given with 5%, right? It's the same thing which was tried with halothane earlier. Now it is with desflurane. Therefore, the second gas effect is obviously useful. Finally, distribution of the anesthetic into the tissues. Ultimately, that is where we want the inhalational agents to reach. And the vessel, I told you about vessel-rich group, and then the muscles, and then finally the fat. And actually, the cartilages and the blood, bones are organs or the tissues which don't receive or receive very negligible volume of blood. Therefore, you can say comfortably that no inhalational agents reach the cartilages and the bones. The rate of increase of anesthetic partial pressure within each tissue is determined by tissue-specific arterial blood flow. When you talk about the cerebral blood flow, effective volume, that's a product of anatomic volume, tissue blood partition coefficient, and the tissue blood solubility coefficient, and anesthetic partial pressure gradient between the arterial blood and the tissue. Till now, we have learned about the factors raising the alveolar concentration, the FA by FI. It depends on the inspired concentration, basically the dial concentration, and the fresh gas flows. And the alveolar ventilation, the time constants, and anesthetic uptake by the blood, and finally the concentration and the second gas effects. And the uptake from the lung, they are decided by the solubility in blood, cardiac output, and the mixed venous anesthetic concentration till the tissue uptake of anesthetic. And solubility is defined in terms of the partition coefficient, and partition coefficient is the ratio of the amount of substance present in one phase compared with another, the two phases being of equal volume and in equilibrium. Okay. This I would like to reiterate again, because you need to remember this at all times. Poor solubility allows rapid induction, and the more soluble the anesthetic is, it is taken up faster, and then therefore there is slower rise in alveolar concentration, and therefore the high solubility means that there is slow induction. I have already told you about desflurane versus methoxyflurane, or in practice the halothane. Cardiac output, I had given you a chart on from Miller, the graph from Miller, which says the greater the cardiac output, more drug will be taken up. Therefore, there is slower rise in the alveolar concentration. Therefore, the induction becomes much slower. And the alveolar to venous anesthetic gradient, again, this is what determines how the vapors move. And please remember that everything what happens during induction, exactly the opposite happens during the reversal, or when the patient is being woken up by you. And I want you to remember that vessel-rich group takes about 4 to 8 minutes for the equilibration to happen. And the muscle group takes about 2 to 6 hours for the equilibration to happen. And when we say equilibration, whatever goes in should come out. And the fat takes about 3 to 4 days of anesthetic to achieve the equilibration. And in effect, it is impossible to reach equilibration, but still fat will, whatever gets into the fat over the period of anesthetic will slowly come out. The reverse is true. The tissue uptake equals the uptake from the lungs, and the tissue blood partition coefficient. Let's skip all this. Yeah, this is what I said in the beginning. Please remember that only 10% of the body mass is the vessel-rich group: brain, heart, lungs, kidneys, pancreas, blood, and the glands. But it receives about 75% of the cardiac output. That is why they're called vessel-rich, and the induction becomes much faster when so much of blood is pumped into these organs. Muscle contributes to about 50% of the body mass, but it receives only 19% of the cardiac output. And the fat contributes to about 20% of the body mass, but it receives about 6% of the cardiac output. And vessel poor, I told you, hardly gets any cardiac output, though it contributes to about 20% of the body mass. That's why, as I said, 10% to 75% is absolutely significant, and it helps us to achieve the VMA. And we have talked about that. Time constants, please read them up when you can. Nitrous oxide takes about 3 time constants, whereas sevoflurane in 3 time constants reaches about 5.1%. And forget about methoxyflurane. 95%, when you talk about 3 time constants, it should be 95% at the target organs, and 98% with 4 time constants, and it's not needed to that extent. 3 time constant should be more than enough to induce our patients. This is another graph which is better known and remembered, and you should know about the first knee and the second knee, where the initial rise is because of the alveolar wash-in. We talked about that. Then the first knee is basically where the blood solubility and that is a BC section basically. And second knee or the bend is equilibration with the VRG, vessel rich group, and third knee, we don't see it here in this, and that's with the equilibration of the muscle group, which may not happen with most of our anesthetics because the surgery may not last that long. Last slides, I'm extremely sorry. I have taken a lot of Sanish's time too, I think. Mapleson's hydraulic model is, I talked about that in the beginning, 1973, the Mapleson model. The anesthetic gas here, the beauty of this particular, no, the last slides, please, last slide. Cross-sectional, surface of each cylinder corresponds to its vital capacity. And when you talk about what is supplied to the oral cavity or the endotracheal tube, then that means that the ventilation to the lungs, they're almost the same because there is nothing to differentiate there, nothing happens in between. And then the vessel rich group, and then we also talked about how much each one contributes to and the fat. And diameter of the pipes, it actually talks about, correlates to the lambda, that is blood gas coefficient, and then the cardiac output to each group, and 75% to the vessel rich group and 18% to muscle group, and hardly anything to the fat group. The height of the column of fluid in each cylinder corresponds to the partial pressure of the anesthetic in that cylinder, right? This absolutely beautifully depicted hydraulic model, and I think we should remember this at all times. Recovery, as I said, it is exactly the opposite of what happens in the beginning, and only the difference between induction and recovery are induction can be accelerated by the overpressure, which offsets solubility and uptake, but the inspired concentration cannot be reduced to below zero. Therefore, pressure gradient will remain almost much lesser than what we do during induction, because during induction, the alveoli and beyond, the partial pressures are almost zero. The inhalational agents aren't there, but that cannot be achieved during recovery. All the tissues initially have the same anesthetic partial pressure, that is zero, including the excluding the machine maybe. On recovery, the tissue partial pressures are variable even at the end. And this is an absolute last slide. Increased solubility slows recovery, and increasing the ventilation may help the recovery from potent agents, and prolonged anesthesia delays recovery, because we talked about that, the muscle group and fat getting saturated with or equilibrated with inhalational agents. There's no concentration effect on emergence. I won't talk about the diffusion hypoxia. Yeah, this is one slide which you can remember at the end. It makes everything absolutely easy for you. Okay. Thank you so much. Thanks, ISA Kerala team, again, for giving me an opportunity to visit this particular important topic, and hope it has been of some help to the postgraduates in the group. Thank you so much. And again, sorry for taking extraordinarily long time.
That's no problem, sir. Sanish must be happy because you have covered the basics. It's a difficult topic though. And are you comfortable taking up the questions now or after Sanish, Dr. Sanish?
I think we'll allow Sanish to, meanwhile, I will try to type out the answers if I can in the chat box. We'll allow Sanish to take over.
Yeah, Sanish will be going to talk about contemporary anesthetic agents. So from theory to students, we are taking students to practical exams, practical sessions. So Dr. Sanish is a very known to postgraduate students because he maintains the anesthesia tool YouTube channel and is the author of review in clinical anesthesia for postgraduate students. And Presently, he's a senior consultant and a postgraduate teacher in Anandapuri Hospitals, Trivandrum. Over to Dr. Sanish.
Thank you, Dr. Rajesh. And I thank ISA Kerala, the academic wing, for organizing this postgraduate update program and making me part of this program. Today, actually, in fact, I feel very proud and happy to be in the panel along with Dr. Madhusudan Upadhyay, who has been my professor, and I would proudly say that I was lucky enough to have him as my mentor. Okay, I happened to work as his colleague for a good number of years in my initial part of my career also. I'm fortunate for that. So talking about an ideal mentor, let me come to my topic per se. I think I'm audible, right, Dr. Rajesh?
Yeah, you are.
Oh,
You are
okay,
audible.
okay, fine. So we are discussing about inhalational anesthetic agents, and my approach will be to give an overall of their physical, chemical properties and comparison. And in between, when something pertinent for discussion is there, I'll deviate, do the discussion and come back to the mainstream. This is how I have planned, because during Viva also what happens is you will be asked to compare the inhaled anesthetics, mostly contemporary inhaled anesthetics, and maybe you will be quizzed on some of the salient features, maybe something which appears in the literature or something is very pertinent to that particular agent. So that's how I have decided. So let's start with trying to explore what exactly you mean by an ideal inhaled anesthetic. Okay, so when we speak about inhaled anesthetic, we need we need high potency, low solubility in blood and tissues. You know the reason already. Basically, our idea is to promote rapid equilibration and elimination. You know that today's fast life is all about fast in, fast out, right? And we don't want any deleterious effect on any organ function. Say, for example, we don't want respiratory depression, we don't want airway irritation, we don't want post-op nausea, vomiting. Kidney should be safe, liver should be safe, and so on and so forth. And plus, we are more greedy that we'll expect some additional benefits like myocardial ischemic protection. Okay, so we don't entertain any physical or metabolic degradation so that our agent can be used with very low flows. We don't want any reaction in CO2 absorbers or with filters, tubings, or connections. Occupational exposure, nowadays the working hours are long, the surgeries are long, but we don't want any long-term negative impacts on our healthcare personnel working with these inhaled anesthetics. There should not be any environmental impact, including during manufacturing. And of course, we don't accept any high acquisition costs. So these are our criteria for an ideal inhaled anesthetics. Again, going further in PACU also, post-anesthesia care also, we are actually concerned about the residual effects of the agents used inside the OT. Maybe like decreased ventilatory response to hypoxia, hypercarbia, any compromised airway patency, laryngopharyngeal dysfunction, post-pulmonary complications, and cognitive dysfunction, etc., etc. In fact, actually, our concerns extend up to and as long as an year or more until say into death or mortality, morbidity, all these things are taken into our purview. This is how we try to select our agents. So our idea is to have an ideal inhaled anesthetic, but have you got one? I don't think anybody will agree if I say we have an ideal anesthetic at hand. But of course, we'll believe that we have many agents which qualify as near ideal ones. Okay. And this is the bottom line. It is not the drug that matters, but the way it is used. This is the key principle, and that forms a part of art anesthetics. I don't know if I am true if I say we have a good number, because many of the institutions, our choices are truly limited though. But for exam purpose, we'll go beyond that. Okay. Again, as Dr. Madhusudan sir mentioned, I have taken the comparison chart from the Miller itself. So here we have the chemical structures and properties of inhaled anesthetics. At the outset, let me confess that this topic many people will describe as a volatile topic, right? Volatile topic means the blood gas partition coefficient is very low. So towards the end of today's session, we'll see how many people have actually got their blood gas partition coefficient much to the favorable end. Like, even though it is volatile, we have to get it condensed. Okay, so this is the comparison chart. You have the chronological order. Nitrous oxide is there, halothane 1956, going to isoflurane 1969, 81 sevoflurane came, 1990s desflurane came. I remember one of the questions one of my professors asked before I went to take my board exam, that have you used any ether? That time I said I'm not fortunate to use any ether because I have not seen ether actually. Actually, that time he laughed and said, then what are you using when you are using isoflurane, sevoflurane, desflurane? Because all are ethers, but they are fluorinated ethers. That is actually given by the name fluorine at the latter part of their name. And you can see this ether linkage, oxygen linked to alkyl or aryl group on either side. It is the ether linkage. These are fluorinated ethers. So we can still proudly say that we have used ethers, but a fluorinated ether. How about alkane? We don't find this ether linkage here. Halothane is an alkane. Okay, fine. So just a point to remember for my postgraduate friends. Let's go for a brief rapid comparison. If you go through the molecular weight comparison, you can find that halothane, isoflurane, sevoflurane, the molecular weight is in and around 200. So in our calculation of 1 ml of liquid agent giving out to this many ml of vapor, we can actually have a common calculation and have a rule of thumb when you are answering the Viva question. Coming to boiling point, it's halothane is 50.2, enflurane 56.5, isoflurane 48.5, 58.6, all are in and around 50 degrees Celsius. But our newest friend, desflurane, has a boiling point of 22.8. That means almost at room temperature, it starts to boil. That's why we treat desflurane as a separate agent, a separate class altogether, because the desflurane is the only vapor which requires a heated electricity supplied, external heat supplied vaporizer, Tech 6 vaporizer. Okay, so there, because of these different physical properties, desflurane needs to be treated on a different way. It cannot be used in our regular flow over other Tech vaporizers. Coming to next property, vapor pressure, you can see again a comparable ones, halothane 243, isoflurane 238, sevoflurane 157. But yes, again, desflurane is way ahead or way different, odd man out, having a vapor pressure of 666, which is very close to atmospheric pressure, that is 760 millimeters of mercury. That is again another reason why we need a specific Tech 6 vaporizer for desflurane. Coming to blood gas partition coefficient, halothane has 2.5, or isoflurane has 1.3, sevoflurane has 0.69, desflurane has 0.45 or 0.42 as per some of the authors. So the lesser the blood gas partition coefficient, faster will be the induction. We have already mentioned. Okay. Nitrous oxide has again a comparable one like 0.47. This is the blood gas partition coefficient at 37 degrees Celsius. Okay, coming to MAC of halothane is 0.75, isoflurane is 1.28, sevoflurane is 2.05, and desflurane it is 6. So when it comes to potency, it's a different game altogether, because desflurane we need as high as 6%, whereas halothane we need only 0.75. You know that halothane vaporizer we can dial up to 5%. That means you can give much more MAC multiples for a volatile induction with halothane. Compared to sevoflurane, it's 2%. So we can't give that much higher number of MAC multiples when we are using sevoflurane for induction. Having said that, I request all my postgraduate friends to remember that a single property cannot be used to explain the actual effect. Okay, sevoflurane is more acceptable. It has less cardiac depression, less bradycardia tendency, so we can use actually dial down technique for mask induction or inhalation induction. But halothane is a tricky one. It has cardiac depressant action. It can trigger arrhythmia along with other stimuli. So we go dial up method for halothane induction. So we don't rely on a single factor or parameter to explain any of the effects. So as I go along my lecture, don't catch me saying one property, because ultimately it's a holistic approach. That's why from theoretical extrapolation, we may have to go and check actually whether it happens. That is today's era of evidence-based medicine. Okay, here I have given color code for our agents. Halothane is red, isoflurane is purple, sevoflurane yellow, and desflurane is blue. Again, nitrous oxide is a different entity. We can't consider it all along our volatile anesthetics, because it exists as gas, because its boiling point is minus 88.5. Its properties are different. Again, I would like to stress on this point. MAC immobility is 104%, which, as Madhusudan sir has already mentioned, is impossible. And how to explain this 104%? That means in 1 atmospheric pressure, we cannot achieve 1 MAC at all. Even if we raise it up to 100%, that also implies that we are not giving oxygen at all, and 20 to 21% oxygen is anybody's birthright. So going beyond 80% is almost unthinkable, and it should not be done. This is basically an extrapolated value, and maybe at higher atmospheric pressures, probably we can use it. But we'll have a different agent, which we'll be discussing in a short while, that is xenon. Okay, blood gas partition coefficient was already discussed, so I'm skipping it. Here actually I have plotted the oil gas partition coefficient and the MAC of anesthetic partial pressure. Here this is an exponential graph. The scale is from 1 to 10 to 100 to 1000. Here also 1% to 10% to 100%. So it's an exponential kind of projection. But again, you can find a linear relationship. As oil gas partition coefficient goes up, the potency goes up. So you can see 0.75% halothane is the MAC. And when we go up, desflurane needs 6% to do the trick, 1 MAC, and nitrous oxide is 104%. But to keep in mind that it is not one single property. Here we can plot the MAC, but different property, how it binds with the tissue, how it saturates the tissue also matters when it comes to actual effect of the volatile anesthetic agent. Here again, it's a comparison chart, which is very important from exam point of view. Here you can find the extent of tissue metabolism. Since I am trying to confine this discussion to the contemporary inhaled anesthetics, I am not sure with, whether everybody will agree if I include halothane in this list, because many of the institutions we may not find halothane at all. But again, for academic purpose, definitely halothane is in action now. It undergoes tissue metabolism to the extent of 25% in comparison with 0.2% of isoflurane, 0.02% of desflurane, and maybe 2 to 4% of sevoflurane. That means these agents are generally exhaled through the pulmonary route itself and their tissue metabolism is almost negligible to be fact. Like halothane, we are expecting some hepatic toxicity. There is a 1 in 20,000, 20,000 incidence of fulminant hepatitis incidence with halothane. But when it comes to isoflurane, desflurane, it's almost non-existent. Now we'll go system by system. We'll start with the respiratory system. Generally, volatile anesthetics produce bronchodilation. How it is possible? It's through decreases in cytoplasmic ionized calcium concentration and or a reduction in calcium sensitivity of airway smooth muscle. So volatile anesthetics attenuate an increase in pulmonary airway resistance induced by chemical or mechanical stimulation. They generally depress ventilatory function and blunt the ventilatory response to hypercapnia and hypoxia. We'll see the trend now. So these are the comparison or the trend chart of our volatile agents. Volatile agents generally cause a tachypnea tendency. Here you can see the breath rate goes up with different inhalational agent. The only one showing a different trend is xenon, because this is one of the reasons why I decided to discuss xenon a little later towards the latter part of my talk. Tidal volume generally comes down. Again, xenon is an exception here. Minute ventilation comes down, and because of the ventilatory depression, there is an increase in the arterial PaCO2. And what happens to respiratory system resistance after tracheal intubation? We can compare different agents. Here you can find with the thiopentone in nitrous oxide and desflurane, there is not much relaxation. But other agents, depending on the color code, you can find isoflurane, desflurane, and sevoflurane cause reduction in the respiratory system resistance from the baseline. As during induction, it comes down drastically, and then it goes to almost a plateau afterwards. And now let's compare the effect of these agents on the pulmonary resistance in a laboratory lung model. Here one message is, as we increase the MAC, increase the concentration, the effect is more. Here you can find that desflurane causes marked increase in the resistance value when we go up from 1 MAC to 1.5 to 2 MAC, whereas the effect of sevoflurane, isoflurane is relatively negligible when compared to desflurane. So obviously, because of this airway irritation property, desflurane is not an agent for mask induction or inhalational induction, because it's an airway irritant. Again, checking on the airway irritation property, I have taken statistics from different authors. Here we can find that 1 MAC to 1.5 to 2 MAC, the increase in the degree of airway irritation goes up. 2 MAC, it causes almost 75% incidence with the desflurane, 1 MAC 30%, but 1.5 MAC around 30%, but 1 MAC, it's not much elevated according to this set of authors. Okay, so desflurane and pungency, the take-home message is avoid desflurane in patients with reactive airway disease altogether. Okay, sevoflurane causes the least amount of subjective airway irritation and is the anesthetic of choice for inhaled induction of anesthesia in pediatric population. Inhaled anesthetics reduce the rate of mucus clearance and affect the function of type 2 alveolar cells. These effects can potentially contribute to postoperative pulmonary complication. Let's compare the effects in blocking the ciliary motility. Sevoflurane has the least impact on the tracheal epithelial cell ciliary motility compared to other agents like halothane and isoflurane. Again, volatile agents generally cause an inhibition of hypoxic pulmonary vasoconstriction, and though the overall effect is a small one, it can definitely contribute to worsening of hypoxemia in patients with underlying pulmonary disease. Preclinical and clinical evidence suggests therapeutic potential of isoflurane and sevoflurane in acute lung injury. We'll discuss the role of these volatile agents in critical care a little while later. Let's go into the heart of the topic, cardiovascular effects. This is the nutshell comparing the effects of halothane, isoflurane, sevoflurane, and desflurane. Blood pressure effect, halothane, dose-dependent hypotension is there. Again, isoflurane also it is there, but to a lesser extent. Vascular effect of halothane is negligible. Isoflurane causes vasodilation. Sevoflurane also causes a little bit of vasodilation. Desflurane initially causes vasoconstriction and later proceed to vasodilation. Again, inotropic effect, I have already mentioned, halothane has a negative inotropic effect and a negative chronotropic effect, whereas isoflurane is slightly negative inotropic effect and it may cause positive chronotropic or tachycardia effect. Sevoflurane inotropic effect slightly negative only. It can also cause tachycardia when administered more than 1 mAc. Desflurane also will lead to tachycardia. That was a chart taken from uptodate.com. It's again summarized in a different format with regard to cardiac output, SVR, mean arterial pressure, and heart rate. Here, our new friend is peeping in, xenon. Negligible effect on cardiac output, negligible impact on SVR, negligible impact on MAP, and reduces heart rate, which is usually appreciated and targeted by contemporary anesthesiologists. Okay, we are coming to a small diversion because isoflurane mentioned that it can cause powerful coronary vasodilatation, and there were literature examining the possibility of isoflurane leading to coronary steal. For postgraduate friends, I'll quickly go through what coronary steal means. Here you can see a vessel totally occluded. This is the LAD territory, and the dependent myocardium is not getting supplied through LAD. But because of the perfusion pressure along with the circumflex, though there is a stenosis, it gets a collateral supply from the circumflex territory and meets its demands. And actually this circumflex also supplies its territory, normal myocardium. Now what happens when isoflurane is or vasodilator, coronary vasodilator is applied? There will be a vasodilatation. This side actually nothing more can happen because the autoregulatory reserve is exhausted or it's maximally dilated. Here actually the further dilatation is possible, which will reduce the perfusion pressure through this coronary collateral circulation. So actually the circulation which was going through the collateral will be diverted to the normal myocardium, further compromising the circulation to this particular area which was previously supplied by a collateral vessel. So this was the postulated mechanism of coronary steal, and many authors have gone behind this controversy. But the interesting thing is the legacy of isoflurane coronary steal controversy is that it led to a chain of experimental studies that ultimately demonstrated, ironically, that the anesthetic has a preconditioning cardioprotective effect. Okay, so we were trying to blame isoflurane, but they came out with the result that this is possibly contributing to a preconditioning or a cardioprotective effect. No evidence of adverse cardiac changes during isoflurane administration was found as long as hemodynamic variables were tightly controlled. Latter part of the sentence is very important for your kind attention. So let's see what you mean by volatile anesthetic induced preconditioning. And it's an adaptive mechanism by which brief period of reversible ischemia increases the myocardium's tolerance to a subsequent longer period of ischemia. Let's remind ourselves regarding this saying that which does not kill us will make us more stronger. Actually, this quotation was dating back to 1888, but it still holds good, right? So isoflurane, sevoflurane, and desflurane have cardioprotective effects. Isoflurane provides early and late preconditioning. Sevoflurane has higher preconditioning effects on previously non-preconditioned heart. There were enough and more literature on this study, and many of the institutions dealing with the cardiac anesthesia were very enthusiastically pursuing this idea. and they were examining preconditioning cardiac anesthesia. Where are we? What is the present status? The meta-analysis, and I found a few literature with interesting finding. Here, this journal says the choice of anesthetic agent for non-cardiac surgery did not significantly affect the development of major adverse cardiac effects in patients with previous coronary stent implantation. That means for non-cardiac surgery, okay, after PCI, cardiovascular outcomes, there is nothing much to choose from. Those days, I think till 2014-16, the ACC-AHA guidelines were recommending that this protective effect is more valid in cardiac surgery at least. So this journal, what it describes is the evidence of benefit of volatile anesthetics in non-cardiac surgery is less robust. Okay, so non-cardiac surgery, there is no great evidence favoring ischemic protection. Now, the recent journals, New England Journal of Medicine 2019, they have examined volatile anesthetic agents versus TIVA for cardiac surgery. And in conclusion, among patients undergoing elective isolated CABG, an intraoperative anesthetic regimen that included volatile anesthetics did not result in significantly fewer deaths at 30 days or even 1 year after a regimen of TIVA anesthesia. So here the story is taking another U-turn. Again, another article which appeared in 2020 in Journal of Cardiothoracic and Vascular Anesthesia. They have compared TIVA versus volatile anesthetics. They have mentioned that TIVA is associated with better survival outcomes after CABG. So actually we have taken a 180-degree turn. They have examined the 90-day mortality, 1-year mortality, and 3-year mortality, and they have mentioned it's statistically significant. Though we have to wait, these are some isolated literatures, we have to wait till our recommending societies come out with a stable recommendation with the robust evidence. Okay. Myocardial preconditioning with volatile anesthetics. Goodbye to all that. This is the editorial which appeared in that particular issue of Journal of Cardiothoracic and Vascular Anesthesia. They have mentioned that volatile anesthetics provide no protection against adverse outcomes after CABG, but they are associated with rather an increase in mortality in the long term. Okay, so now what we can conclude is we are less certain than we were before. That's the take-home message, and we have to wait for further evidence to emerge. Now we will go to the brain, the central and peripheral nervous system, how our agents act. I have selected a few parameters to compare our contemporary anesthetic agents. And why are we concerned when we are giving, say, neuroanesthesia? Our anesthetic agent and adjuvants can have direct brain effects leading to brain hypoxemia, hernia, or depressed or deranged neurological outcomes. In other words, it can also manipulate other parameters like temperature, PaCO2, mean arterial pressure, the perfusing pressure, the cerebral blood flow, and CMRO2. These things can be interfered with by our anesthetic agents and ultimately lead to brain hypoxia, hernia, or adverse neurological outcome. So both these terms we should be concerned. Okay. This is a nutshell. Halothane basically reduces the CMRO2 but increases cerebral blood flow. It reduces CSF production as well as absorption. Isoflurane also reduces the CMRO2 to a higher degree compared to halothane. So is the case with desflurane, sevoflurane, but their rise in cerebral blood flow is far less compared to halothane. Again, nitrous oxide, CMR is coming down, but cerebral blood flow is going up. Xenon, for a change, CMRO2 comes down significantly and cerebral blood flow also comes down. Okay, what we don't know is its effects on CSF production or CSF absorption, but definitely it reduces the intracranial pressure. So this is the odd man out when we are discussing on neuroanesthesia terms. Here I have plotted a graph on total CMRO2, cerebral metabolic rate O2, 5 ml per 100 gram per minute. This is the baseline. Against in x-axis cerebral blood flow, 50 ml per 100 gram per brain per minute is the normal. And where do we stand with respect to our inhaled agents? inhaled agents, basically they pull down the metabolic rate CMRO2. However, they increase the cerebral blood flow. Again, it should be noted that the rise in MAC leads to rise in cerebral blood flow further. Just to compare among our agents, halothane causes maximal increase in the cerebral blood flow. When it comes to reduction in CMRO2, they are almost comparable. Again, we have to keep in mind how our other agents like ketamine, benzodiazepine, opioids stand in this particular plot of comparison. Benzodiazepines and opioids reduce CMRO2 and reduce cerebral blood flow. Okay, ketamine actually increases cerebral blood flow but increase CMRO2 as well. So this graph is very important for comparison of our agents. Again, kindly note that as we increase the dose or increase the MAC or the percentage of agents, these effects will vary, the extent will keep on changing. Again, there are enough literature discussing the effect of volatile agents on cerebral autoregulation, vasomotor reactivity, and neurovascular coupling. And generally speaking, we can say that the cerebral blood flow is increased by volatile anesthetics. Cerebral autoregulation effect is seen when we give more than 1 MAC of sevoflurane, but more than 1.5 MAC of isoflurane or desflurane. Same with the vasomotor reactivity. Okay, some take-home points. Modern halogenated volatile agents such as isoflurane, sevoflurane, and desflurane are thought to uncouple flow metabolism matching. Okay, so the extent of reduction in flow is or change in flow is not to the extent of change in the metabolism. The vasodilatation mediated by volatile anesthetics occurs independent of the anesthetic depth and is actually the result of direct effect on cerebral vasculature. Compared to isoflurane, sevoflurane is less potent cerebrovascular dilator when cerebral vasodilator when administered at MAC equivalent doses. Cerebral autoregulation remains intact during isoflurane and desflurane at 1 MAC, but above 1.5 MAC, cerebral blood flow pressure passive becomes pressure passive with respect to mean arterial pressure. Sevoflurane at therapeutic doses has been reported to narrow the plateau region of autoregulatory curve that I will come to in the next slide probably. Vasomotor reactivity is preserved during isoflurane administration at therapeutic doses. Conversely, vasodilatation due to hypercapnia as well as vasoconstriction due to hypocapnia are blunted by sevoflurane. In the absence of results from prospective randomized controlled trials, it is premature to conclude that sufficient evidence exists to support the notion that volatile anesthetics are neuroprotective or neurotoxic agents in human. We have to keep on waiting for further literature. Volatile anesthetics have been shown to initiate early ischemic tolerance or preconditioning. We were discussing regard to myocardium in neurons. But the models of focal brain ischemia suggest it can take 24 hours or more for preconditioning to develop fully, which is usually not practical. So this is the cerebral autoregulation curve. I think all the postgraduate friends should be familiar with this curve. Here actually the plot is not only for cerebral perfusion pressure against cerebral blood flow, it also plots the changes with the PaCO2 and PaO2. This is very good graph. We can explain so many things with regard to that. But our topic is volatile anesthetic agent. Here, this is the autoregulation curve. As we keep on giving volatile anesthetic agents, this plateau region is narrowing, and then disappearing almost. That means whenever mean arterial pressure drops, cerebral blood flow drops. Whenever mean arterial pressure goes up, cerebral blood flow increases when we give higher max of volatile agents. That is the problem with our anesthetic agents with regard to cerebral autoregulation. The higher the cerebral blood flow, there is more chance of neuronal adverse events. Now we go to the effects on the liver. We said halothane undergoes 25% metabolism by oxidative phosphorylation via hepatic cytochrome P450 systems. The rest of the current volatile anesthetics, isoflurane, sevo, des, are metabolized very minimally. They are mainly excreted unchanged in exhaled air. The risk of hepatitis correlates to the degree to which volatile anesthetics agents undergo oxidative phosphorylation. This is a comparison of oxidative phosphorylation, sevo, iso, des, and the least with sevoflurane. Okay, so this is the mechanism of how TFAA is generated and ultimately lead to TFA antigens will lead to humoral and cellular sensitization, and during subsequent anesthetic exposure, there is a risk of halothane hepatitis because of hepatocellular damage and necrosis, which can mean mortality. That's why we are concerned while using halothane. Effects on kidneys or renal toxicity. Newer agents have minimal effects on renal physiology. The production of inorganic fluoride by the metabolism of halogenated agents may cause direct nephrotoxicity. Sevoflurane undergoes significant defluorination, and studies have shown that over half of the patients who had prolonged exposure had fluoride levels more than 50 millimoles per liter. These are serum fluoride levels, but evidence of a clinically meaningful effect of sevoflurane on renal function is currently lacking. So I have put this graph from Miller just to show that when it comes to methoxyflurane, the rise in fluoride levels are sustained. Here actually this is a pre-op value, end of anesthesia, and 1, 2, 3, 4, 5 days, 6 days, the high values are still sustained. When it comes to sevoflurane, it comes down drastically from the day 1, 2, and then it goes to almost normal in a day's time. Effects on uterus. This is the literature checking the effects of volatile anesthetics on spontaneous contractility on human pregnant uterine effect. Generally, they are uterine relaxants. Both the strength and frequency of uterine contractions were substantially more reduced to approximately the same degree by halothane, desflurane, sevoflurane compared with isoflurane. However, in situations where rapid and profound uterine muscle depression are required, as with say fetal surgery, sevoflurane or desflurane seem to be the inhalational agents of choice because of their greater uterine depressant effects at lower MAC concentrations, and of course their insolubility allowing the uterine effect to be induced and removed quickly. Another thing is you all know that volatile agents will lead to immobility. Actually, unfortunately, when we define minimum alveolar concentration, where we want to speak on the depth of anesthesia or the CNS effect, we actually rely on a probably spinal cord effect of these agents to cause immobility. Actually, the search is still on. Okay. There remains a possibility that immobilization results from non-specific mechanism, maybe at the spinal cord level also. I think the definite answers are still to come. Generally, exams you might be accused on the impact of compound A when we speak on a comparison of volatile agents. We know that sevoflurane interacts with strong bases like NaOH or KOH in some carbon dioxide absorbers and produce compound A. Compound A is shown to be nephrotoxic in rats. Okay, this animal study results. No study has demonstrated clinically significant nephrotoxicity in humans even after prolonged administration of sevoflurane with low fresh gas flow rates despite significant compound A production. You know what is compound A? Fluoromethyl 2,2-difluoro 1-trifluoromethyl vinyl ether. Okay, so this is the reaction how compound A causes nephrotoxicity. This is again animal study and the mechanism, and the actual evidence in humans is still lacking. However, US FDA recommends use of sevoflurane with fresh gas flow rates more than 1 liter per minute for exposure less than 1 hour and at least 2 liter per minute for exposures more than 1 hour. However, it should be noted that federal agencies in other countries have not made such recommendations, nor have any professional societies. Many institutions during transplant anesthesia and all, they still use sevoflurane along with sometimes very low flow or even metabolic flow anesthesia administration. Another worrying factor is formation of carbon monoxide. CO2 absorbents containing NaOH or KOH can induce production of carbon monoxide. Absorbents containing lithium hydroxide or barium hydroxide are not associated with carbon monoxide production, although these carbon dioxide absorbents are more expensive. So the formation risk is more with desflurane, less with halothane and sevoflurane. Nitrous oxide does not induce carbon monoxide production. A word on neurotoxicity of volatile anesthetics. FDA recommends that the healthcare providers discuss with the pregnant patients and parents of young children the benefits, risk, and appropriate timing of surgery requiring anesthesia that will take longer than 3 hours. However, the degree of risk remains unclear to us. Due to lack of clinical evidence, in April 2017, the FDA modified their warning, stating that the medically necessary procedures in pregnant women and children under the age of 3 should not be delayed and that practitioners should follow their usual practice paradigms. So this is the modification. Regarding teratogenic effects, historically there was significant concern regarding the increased risk of pregnancy loss and association with congenital malformations in the offspring of pregnant women chronically exposed to low levels of inhalational agents such as operating room nurses, surgeons, and of course anesthesiologists. Data are conflicting and the precise extent of risk, if any, is still unclear. However, these concerns resulted in requirements for fastidious scavenging and appropriate vending of inhalational agents. This is an ASA recommendation as well as Occupational Health and Safety Administration OHSA guideline. A word on malignant hypothermia. All potent volatile inhalational agents may cause malignant hypothermia in susceptible individuals. Something on nitrous oxide, some interesting points. It's an NMDA receptor antagonist. It is a potent cerebral vasodilator. We have already shown that it increases intracranial pressure, it increases CMRO2. It is a potent analgesic. And what we are concerned is expansion of air bubbles, say in case of venous air embolism or a case of pneumocephalus, and increased post-op nausea, vomiting. And now we go to some literature examining is nitrous oxide use appropriate in neurosurgical and neurologically at-risk patients. The conclusion they have given is except in few specific circumstances, there exists no conclusive evidence to support the dogmatic avoidance of nitrous oxide in neurosurgical patients. Let's see how other authors feel about it. This is one editorial in 2008 in Anesthesiology. Nitrous oxide in neuroanesthesia, tried and true, or is it a toxin? This is the conclusion. Nitrous oxide, like all our anesthetic agents, is flawed and imperfect, just like any of our other anesthetic agents. But it has served us and our patients for more than 160 years. It is tried and true. Anytime a 162-year-old drug performs in the symphony of care as well as a contemporary alternative, either it deserves respect or maybe the younger generation is getting us nowhere. Again, another literature regarding the effect of nitrous oxide on neurological and neurophysiological function after intracranial aneurysm clipping surgery in a population of patients at risk for ischemic brain injury. That's the beauty of this case selection. Nitrous oxide use had no overall beneficial or detrimental impact on neurological or neuropsychological outcome. Again, they recommend against a blanket no to nitrous oxide. Okay, they are against blanket no. Okay, they say it's as good as any other technique. Effect of nitrous oxide use on long-term neurological and neurophysiological outcome in patients who received temporary proximal artery occlusion during cerebral aneurysm clipping surgery. There is a risk of focal ischemia, but again, there is no evidence to support unconditional avoidance of nitrous oxide in patients at risk for cerebral ischemia. Again, we have a concern that it inhibits methionine synthase in vitamin B12 synthetic pathway. So nitrous oxide may be avoided in patients with disorders of B12, folate, and methionine synthesis or metabolism. Our new friend xenon is a colorless, odorless, noble gas. MAC of this gas is about 63%, which is practically possible. It acts by inhibition of NMDA glutamate receptor. It has excellent cardiovascular stability, which I have mentioned earlier. Rapid induction emergence, faster recovery of cognitive function. It has a proposed neuroprotective impact. Xenon is an expensive anesthetic right now, and PONV incidence for xenon anesthesia is very high. Effect on mean arterial pressure, no vasopressor or volume replacement is required. On intracranial pressure, it may increase ICP due to vasodilatory effect, but hyperventilation effectively mitigates xenon-induced rise in ICP. Cerebral metabolism is decreased much more than what propofol does. Cerebral electrical activity, it may have anti-convulsant effect. So this is the comparison chart between nitrous oxide and xenon. Actually, there is not much comparison with regard to positive effects, but cost efficiency is favorable when it comes to nitrous oxide, and it's not favorable because of its high cost at this point. I would like to bring into your notice the critical care perspective, because critical care people have also started using volatile anesthetics. There are enough literature like this appearing whether volatile anesthetics is a new player emerging in the clinical critical care sedation. Volatile based sedation may provide superior awakening and extubation times in comparison with current intravenous sedation agents like propofol or benzodiazepines. It may possess important end organ protective properties mediated by cytoprotective and anti-inflammatory mechanisms, because these agents may be used for hours together. So the literature is coming up thick and fast discussing on this topic. Another hot topic these days is environmental impact. The carbon dioxide load, global warming potential impact is much higher. Say carbon dioxide is 1, sevoflurane is almost 2000, close to 2000, desflurane it's 3700 plus. And again, ozone depleting potential is mentioned with regard to some of the agents. Global warming potential is described with some volatile agents. We are actually in the era when we discuss environmental sustainability in anesthesia and critical care as a whole. And this topic I would like to approach in a holistic view, not only our anesthetic, inhaled anesthetics, even the TIVA, the propofol, the used plastic syringes, the machinery, the energy consumption, everything mounts to global warming potential and adverse environmental effects. So we need to take a step further, stressing on environmental sustainability in our practice. So how anesthesia can lead the way, encourage low flow and automated end-tidal control anesthesia with the newer machines, with more understanding of the volatile uptake, physiology, the properties, the more sensible use, and the minimal use. Whatever is required you use, do not waste anesthetic gases. And whatever comes out as a waste anesthetic gas should be reclaimed. And there is research is emerging, exploring the potential to reduce emissions to the environment, recycling, reduce, and reuse. Reuse after redistillation of the tab drugs. So these are the thing we have to maintain in our day-to-day practice as well. Environmental susceptibility, sustainability is an important topic that younger generation should be taught and keep in mind during our practice. With this positive note, I'm winding up my talk on inhaled agents. I think I have given an overview on the inhaled anesthetics, their generic properties, and try to discuss some literature, evidence-based impact on our clinical practice. Thanks once again to the organizers of ISA Kerala Postgraduate Uptake, Dr. Binil, Dr. Nasser, and our coordinators, Dr. Vijesh and Dr. Rajesh. Thank you very much. We'll see you in the Q&A session. Thank you.
Thank you, Dr. Sanish. We'll go to the question and answer sessions. Can you answer is there any questions in the chat box?
And I think I was too fast so that they may not be able to put their questions in the chat box.
No, there was one which I think I have answered, and hopefully that settles. And then they wanted something about xenon. Sanish had put up a couple of slides on xenon at the end. Somebody wanted to know whether anyone in India is using. Gangarams was using it when it was launched, and then I think it is like prohibitively costly. I don't think it is being used anymore. I don't know. Maybe I'm ignorant, but according to me, nobody is using right now.
Dr. Vijesh,
Dr. Vijay is not there. Sir, you can proceed. Before moving to next session, you can just announce our next program, which will be held on next Saturday. Our PG update will be held on next Saturday. Our next academic program will be on Monday. That is on 28th December 2020. ISA Kerala academic program, which will be organized by ISA Kollam City branch. And the topic will be the fundamentals of mechanical ventilation by Dr. Vijesh Venugopal, Professor and HOD of Department of Anesthesiology, KMCT Medical College, Calicut. And we all know he is a very good speaker, and he is our past scientific committee coordinator for ISA Kerala State Chapter. So we can expect many things from Dr. Vijesh on next Monday. And our next PG update program will be held on next Saturday. The topics will be NMJ and NNB by Dr. Usha Chennai from Jubilee Mission Medical College. She is a very good speaker. And the second topic is NM neuromuscular monitoring by Dr. Jerry Paul from Amrita Institute of Medical Sciences, Kochi. After that, there will be a case discussion on cataract by Dr. Kailash. And the examiners will be Dr. Radha KR from Government Medical College, Calicut, and Dr. Anand Bangera from KS Hegde, a professor and HOD of KS Hegde Medical College, Medical Academy, Mangalore. Dr. Rajesh, sir, please.
Yeah, there is a query, sir, could you please enlighten more upon concentration effect and second gas effect?
No, I think if I have the patience, I will put it up on the chat box. I think it is better that they read up, because everybody knows about the concentration effect and the second gas effect. I will try to put it up, and if I have the patience.
Okay, sir. Probably because it's a short answer, the 10-mark question. It's
yeah, I know. That will take a lot of time. That's why I didn't go into the details of that even when I spoke. And everybody knows about it, I thought, and I just touched upon it. I will try to put it up on the group.
Yeah. The reason for query may be due to that they are maybe expecting it as a short note.
Yeah, of course. Of course, it is. It is.
Yeah, we'll now from practice, from a clinical examination, we go to, that's a short case presentation. Dr. Avani Sajeevan from Kottayam Medical College. And the internal examiner is Dr. Shanti KS, additional professor and present HOD, Kottayam Government Medical College, Kottayam. And Dr. Ashish Karthik, associate professor, Tracheal Medical College. Over to Dr. Shanti, Dr. Ashish, and Dr. Avani.
Hello? Hello?
Hello, yeah.
It's audible, madam. We can hear.
Yeah, we can hear. Yeah.
Okay. Am I audible?
Yeah, Avani, you are audible.
You can the slides are visible. Yeah, you are audible. Please start.
All, my case presentation is adenotonsillectomy. 18 males coming from Changanasheri. Informant is mother, reliable, complaint, snoring for 1 month, sore throat for 7 days, difficulty in swallowing for 5 days. His present illness: 8-year-old male child presented with history of snoring for past 1 month. He developed a sore throat 1 week back, which was gradually worsened. It was associated with difficulty in swallowing for 5 days. Child complained of pain while taking solid as well as liquid diet. No history of bad breath, ear pain, reduced hearing. No history of fever, running nose, cough. Past history: history of frequent episodes of sore throat and fever for the past 3 years, approximately 4 episodes per year. Each episode lasts for 5 to 7 days, which was relieved by taking medication. Each episode was associated with reduced food intake. No history of seizure disorders, febrile seizures in the past. No history of drug allergy and food allergy. No history suggestive of any bleeding tendency. Antenatal, natal, and postnatal history. Antenatal period was uneventful. Child born of non-consanguineous marriage. Child of full-term normal vaginal delivery. Cried soon after birth. Birth weight is 2.8 kg. Postnatal period was uneventful. Developmental and immunization history. All developmental milestones are achieved normally. Immunized before age. Personal history. Child studying in third standard. Good scholastic performance. Child taking mixed diet. Bowel and bladder habits are normal. Family history. History of systemic hypertension in father. No history of bleeding disorders in the family. Socioeconomic history. Child belongs to upper middle class family. Lives in the Pakka house. General examination. Child is alert, active. Weight is 20 kg. Grade 1 protein energy malnutrition. Height 120 centimeter. Vital signs, pulse rate 98 per minute. Regular, normal volume and character. BP 90 per 60 millimeters of mercury in right upper lip. Respiratory rate is 28 per minute. Temperature is 97.6 degree Fahrenheit in right axilla. No pallor, icterus, cyanosis, clubbing and edema. Bilateral jugulodigastric lymph nodes are enlarged. Head to foot examination appears normal. No adenoid fissures. IV axis is visualized. Airway examination, myelopathy grade 2. Temporomandibular joint mobility is adequate. No loose teeth. Neck movements are normal. Coming to local examination, oral cavity, lip, buccal mucosa, soft palate, hard palate appears normal. Uvula appears central. Tongue appears normal. Dental caries present. Tonsil, bilateral tonsil enlarged. No congestion. No follicles or membrane over the tonsil. Anterior pillar and posterior pillars are normal. Ear and nose appears normal. Coming to systemic examination, respiratory system. On inspection, shape of chest appears normal. Respiratory rate is 28 per minute. Regular. Bilateral chest movements appears normal and equal. No dilated veins and scars. On palpation, bilateral chest movements are equal. Auscultation, bilateral air entry are equal. No added sound. Cardiovascular system, pulse rate is 98 per minute, regular. Blood pressure 90 per 60 millimeters of mercury. JVP not raised. On inspection, shape of precordium appears normal. Apex beat visible lateral to left nipple. On palpation, apex beat is felt at the left to fifth intercostal space. Auscultation, S1 and S2 heard normally, no murmurs. Central nervous system examination, higher mental functions are normal. Sensory motor system are normal. Cranial nerves and gait are normal. Parabdomen soft, non-tender, no organomegaly. Coming to the summary, 8-year-old child, history of snoring for 1 month with history of sore throat for the past 1 week and difficulty in swallowing for 5 days. History of frequent episodes of sore throat and fever for the past 3 years, 4 episodes per year approximately. Each episode lasts for 5 to 7 days, which was relieved by taking medication. On examination, bilateral tonsils are enlarged, no congestion, airway appears normal. Diagnosis is adenotonsillitis, admitted for elective adenotonsillectomy.
Okay. Hello.
Hello.
Ashish.
Madam, good evening and good evening to all senior
hi.
faculty in the group. Good evening to organizers and good evening to Avani. I think this is a late time and we will keep the exam very short and simple. And when you come to the short case, it is usually the end of long cases and you don't have much determinant to pass and fail. We will be just thinking about whether to provide first class or distinction. Am I right? Avani, I got few doubts to clear. We will try to keep it very simple and informative as far as possible. And as you know, the tonsillectomy per se is a short case and it's rather simple on discussion. Can I have a few doubts cleared, madam? The internal examiner.
Okay.
Madam, actually, I got what is exactly, how many you mean by Pakka house? I have not heard of it.
Classification that is Pakka house.
What is that? What for viewers' interest? Can you share what is this? And for interest, we just want to know that we have not discussed anything regarding the case presentation, just to keep the same feature of an external examiner.
Okay. Hmm.
So can you highlight this?
Child is sleeping according to socioeconomic history. Child, it's to rule out any allergic.
Okay, so so you want to say that this patient is not having a significant allergy which precipitate this, right?
Okay. Hmm.
Okay, anyway, madam, you want to start?
No, you just start. That's okay.
So we will be discussing the topics one by one for
Okay.
a PG point of view.
We'll go in order. Okay.
Yeah, yeah. So the first thing will be, can you highlight on the anatomical aspect of this? Like what is the blood supply? What is the venous drainage? What is the nerve supply? And what is the
Adenotonsillar.
and what is the
tonsil.
lymphatic drainage of adenotonsil?
Tonsil is an ovoid mass of lymphoid tissue situated in the lateral wall of the oropharynx between the anterior and posterior pillar. Tonsil and adenoid are the part of Valder's ring. Valder's ring comprises of mass of lymphoid tissue scattered in the pharynx that comprises adenoid, tubal tonsil, palatine tonsil, and lingual tonsil. Coming to the blood supply, arterial supply, superior pole is supplied by ascending pharyngeal artery, lesser palatine artery. Inferior pole is supplied by tonsillar branch of facial artery, dorsal lingual artery, and ascending palatine artery. Venous drainage is into the plexus around the tonsillar capsule and paratonsillar vein that may drain into the pharyngeal plexus and the common facial vein. Nerve supply is by the lesser palatine nerve and glossopharyngeal nerve.
Okay, that's very nice actually. I just want to add a point, like you are very familiar with the word Walder ring, you know. See, there is something known as Walder gland. Have you heard of it? Walder gland is actually situated in the eyelid, and Walder is an anatomist, German anatomist, who has actually contributed to neuronal theory, and he is also a person who has given names of the chromosome. So that is something which you can add on it if you want to get an additional information. Anyway, the other point which we will discuss is one point known as malt. Have you heard of it?
Mucosal associated
Very good.
lymphoid tissue.
That's right. Because the Walder ring per se is an incomplete ring, isn't it? So many of the lymphatics are situated in the posterior oral space. That is what is known as malt. So this being the first primary defense, so even if you do the adenotonsillectomy, we are not actually taking away the whole first line defense. And as you know, the incidence of adenotonsillectomy or the indications of adenotonsillectomy are coming down very significantly, because most of the pediatricians nowadays trying to preserve the tonsil depending upon the clinical scenario, if they can correct it. So can you just highlight what are the current scenarios where they suggest an adenotonsillectomy?
Just indications for adenotonsillectomy
that's right.
nowadays.
That's, yeah.
The absolute indications are hypertrophy of the tonsil causing upper airway obstruction, obstructive sleep apnea, difficulty in speech or dysphagia, recurrent tonsillitis, that is more than 7 episodes per year for the last 1 year, or more than 5 episodes per year for the last 2 years, or more than 3 episodes per year for the last 3 years.
Very good.
Or tonsillitis that causing febrile seizure or any suspicion of malignancy, and a peritonsillar abscess that is not managed with a medical treatment. Then the relative indications are streptococcal carriers and diphtheria carriers.
Very good. Now, among the point which you suggested regarding the indications, have you noticed that you have mentioned a suspicion of malignancy, isn't it?
Yes, sir.
So that is very important for us, because in most of the time, being an anesthesiologist, we don't get much of a role in diagnosing as well as deciding to operate, whether to post the patient for tonsillectomy or not, isn't it? But see, when you can do your examination, you definitely get a clue of malignancy. So can you highlight the point which you can guess from your examination that you are going to deal sometimes a case of malignancy of tonsil? Not only tonsil, it can be a secondary also. Yeah, from our history as well as from the clinical examination.
While taking history, there is a short duration with increase in size, which is
rapid increase in size. That's what's your very
rapid
good.
increase in size.
Okay.
Then they may cause obstructive features, and they may cause bleeding via history. On examination, there may be a large irregular mass that have a fixed boundary that may infiltrate anterior or posterior pillars, and it may be highly vascular, and lymph node will be enlarged. Neck nodes, that is bilateral jugulo-digastric.
That's right. One more point what you can say is you in your examination you mentioned that both the tonsils on oropharyngeal examination remains bilaterally enlarged and symmetrical, isn't it?
Yes, sir.
If you note that one tonsil is enlarged to a greater extent than the other, or an asymmetrical enlargement in a tonsil along with multiple lymph nodes suggests you are probably going to deal a malignant tonsil, which in turn tell you that you are in a chance to develop a higher amount of bleeding intraoperatively, which in turn tell you that when you are planning and providing a perioperative anesthesia, these patients who has got a higher chance of intraoperative bleed can go for a postoperative bleeding as well. They have a higher chance for postoperative bleeding. Okay, so that is the clinical significance of identifying a malignant tonsil or a tonsil due to an enlarged due to a malignancy from the benign tonsillitis. Okay, so that is one point. So, madam, would you like to add something, or you want to ask something?
No, we'll ask something like no. Previously, the indication was like most of the children will be coming with a recurrent infection, but now the trend has changed. It seems that is nowadays it is more of obstructive sleep apnea. Then what is the difference what will be the difference when a child is having OSA and compared to an adult? History and
Obstructive sleep apnea is the cessation of breathing that lasts for more than 10 seconds during the sleep, and it is more than 5 episodes per hour. Usually, adult present with snoring, disturbed sleep, daytime somnolence, morning headache. But the presentation in the child will be different. The child usually present with irritable child, failure to thrive, poor scholastic performance.
okay.
Avani, can you just mention how is obstructive sleep apnea important to an anesthesiologist? Identifying obstructive sleep apnea in a child, as you rightly mentioned, which is a very important point, can become significant or relevant to us. Or how can? Yeah, that's right. I think you got the point.
Upper area obstruction that is usually causing obstructive sleep apnea. So in the period, when the medications are given or sedative drugs are given, the child goes airway obstruction, and also in the recovery position. And in the recovery period also, there is more complications of upper airway obstruction, and difficult airway can occur in secondary to, in case of obstructive sleep apnea, the fascias may be maybe have particular fascias, and there may be airway anomalies will be associated. So difficult airway should be anticipated. And in case of prolonged obstructive sleep apnea, there may be secondary polycythemia or right ventricular hypertrophy that may also complicate anesthesia.
Right ventricular hypertrophy secondary to pulmonary arterial hypertension. Okay.
Avani, you have rightly pointed out. The point is, number one, if you diagnose an OSA for a patient with tonsillectomy, you are expecting more post-operative complications. So OSA, presence of OSA in a patient with tonsillectomy, anticipate post-operative complication, number one. Okay. So that is an important point which you need to understand. Second is these patients can have eustachian tube dysfunction. And along with that, this patient can have has got RVH features and ECG changes, if at all, there, and probably pulmonary hypertension, though it is not very common. Most of the time, before that, they come to us and get operated. Anyway, the point is OSA, think of complication, more chance of complication. Okay. Now, can we think how do you optimize this patient, or what is the goal of providing anesthesia in a patient for tonsillectomy? Or what are your goals, anesthetic goals?
Anesthetic goals are mainly concerned with patient preparation and pre-medication. It is an airway sharing surgery between the surgeon and anesthetics. So airway should be protected throughout the surgery to avoid any obstruction or displacement of the endotracheal tube, and maintain deep plane of general anesthesia throughout the surgery to avoid the reflex tachycardia or hypertension, and maintain muscle relaxation that will allow the placement of the mouth gap and or prevent bucking or straining on the tube, and a rapid recovery of consciousness and return of airway reflexes is desired. And tonsil is highly vascular, so blood loss should be monitored, and postoperative analgesia, postoperative nausea, vomiting should be tackled.
So Avani has enlisted a group of goals which is very big to satisfy. Anyway, that that gives an entire list of goals which you can do. Anyway, what is a pre-operative preparation which you can do for this patient? Because we will not, we have short span of time, so we will just go ahead with the discussion. So how will you pre-operatively prepare this patient? Madam, if you have something to contribute.
No, this is okay.
Fine.
Patient is coming in the pediatric age group, so pre-operative anxiety should be addressed. At the time of pre-operative assessment, create a good rapport with the child and the parent.
Avani, can I interrupt you?
Okay, sir.
See, can you just recollect the age of this patient for the viewers? Okay, so it's an 8-year-old child.
8-year-old child.
Yeah. So now you can proceed, please.
So
create a good rapport with the child and the parent, and parents should be counseled about the surgery and mode of anesthesia and the complications. Then NPO guidelines are 2 hours for clear fluid, 6 hours for liquid diet, and 8 hours for solid diet. And they are prone for a recurrent upper respiratory and lower respiratory tract infection. So active infection at the pre-operative day, that should be controlled pre-operatively. Then to sedate or to reduce the anxiety, pre-medication should be given. Usual pre-medication is oral midazolam, 0.5 mg per kg, 20 minutes prior to the surgery. Other drugs available are oral clonidine, that is 4 microgram per kg, 45 minutes prior to the surgery.
What
then
is your
blood and blood
practice? Yeah, sorry, please go ahead.
Our practice is to give midazolam 0.5 mg per kg 20 minutes prior to surgery.
Okay, so for this patient what's the weight?
20 kg.
20 kg.
Yeah.
10 mg midazolam will be given, 45.
Okay.
I will go for pre-operative investigations.
Yeah.
It include hemoglobin to know about.
Before investigation, I'll give you 2 options. Like, see, there can be 2 possibilities. This patient come to you for your pre-operative checkup 2 days prior or 3 days prior, and you see the patient's nose has got some secretions. It's watery secretion coming out from the nose. That is scenario number 1. And scenario number 2, you have a mucopurulent secretion. So how will you, and the surgeon say that you need to operate both the cases, scenario 1 and scenario 2 at the earliest. So how will you take this, or what will be your suggestion on this to the surgeon?
In the scenario 1, the child have only mild upper respiratory tract infection because there is only nasal congestion, and it should be mucoid discharge, and there is no signs of fever, no chest signs. I will proceed with the surgery because adenotonsillectomy child always have a recurrent upper and lower respiratory tract infection.
And most of
case
the time they will be crying and it can has got some allergy.
In case of second scenario, there is suggestive of better to postpone the surgery for 4 to 6 weeks because their airway will be hyperreactive. That may cause laryngospasm or respiratory complications. So better to postpone the surgery and optimize the child and can taken after 4 to 6 weeks.
Very good. You have made the point very clear. Can you add another other conditions where you will postpone or postpone the case for good for optimizing the patient? The other condition other than mucopurulent.
What are the predictors of respiratory complications like?
Others are
when a child is having a URL.
Madam is an excellent internal examiner, isn't it? Yeah.
Have to be, no?
Yeah, sure, madam. Yeah.
History of productive cough with copious secretion. Then if there is a history of fever, if
Good.
any history of premature if the child is a premature child, aged less than 5 years, there is a history of passive smoking in the family. If there is a history of snoring, obstructive sleep apnea, or airway reactive diseases, and if it is an airway surgery, then on investigation wise, increase the total count. These are the predictors for postponing surgery.
Okay, fine. Shall we go to investigations?
The investigations are hemoglobin, to know about the oxygen carrying capacity and to calculate the maximum allowable blood loss, and to rule out the anemia secondary to malnutrition, and to rule out the polycythemia secondary to obstructive sleep apnea, and the total count to rule out the infection, platelet count to rule out any bleeding tendency. Coagulation profile include bleeding time, clotting time, PTNR and APTT to rule out any bleeding tendency. Blood grouping and cross-matching should be done and blood should be kept ready.
So will you ask for any chest X-ray, ECG? What is the rule? Which is the situation will you ask for an ECG or chest X-ray? Chest X-ray.
As a complication of obstructive sleep.
Yeah.
Obstructive
If there is a history of OSA, to rule out what?
We can go for right ventricular hypertrophy and RV strain pattern will be seen in ECG.
Okay.
Is there any conditions after getting the investigations you say that no, I am not ready to take up this case now? I am trying to ask you what are the absolute contraindications for tonsillectomy?
Hemoglobin less than 10 gram per deciliter and increase the total count.
Very good. So that means when the patient is having active infection. So increased total count, high grade fever, presence of chest signs, and mucopurulent discharge all contribute are all contributions to you saying that you can optimize this patient and take up later, isn't it? Now, is there anything which you can do when this patient come to your pre-operative room? A simple investigation which tell you that, as you know, the polysomnography in children are not very common in our place, no? So, and most of the time we will not be able to assess the OSA also. And is there any simple investigation which can tell you that will be helpful even in the post-op also to compare at least, which will help you? Very good. That is room air saturation.
Room air saturation.
Room air saturation is something which you will be looking for. Okay. Yeah. Madam, you want to add anything?
No. Then, if there is an upper respiratory infection, how will you modify your technique of anesthesia? That is pre-op preparation, perioperative. How will you modify your management?
Pre-operatively, child should be optimized with a saline nasal drop, steam inhalation. Inhalation with beta-2 agonists like salbutamol can be given. Then steroids can also be given. And during the intraoperative period, anticholinergics can be given to reduce the secretions, like a glycopyrrolate can be given. Then drug like propofol are used for induction that may cause less airway irritancy. And maintain a deep plane of anesthesia throughout the surgery to prevent the bucking or straining on the tube. And humidification and hydration that will help to minimize the drying and insipation of secretions.
Okay.
Two more practical things which you can say is, you said passive smoking is one problem. You can ask the parents to stop smoking. And you can also, in practically, you can ask the patients to remain at home rather than not asking the visitors, much of visitors, to prevent the secondary infection during that time while optimizing.
Okay.
Just a practical point if you need it. Yeah. So shall we go to the theater?
Yeah.
Okay. So how do you?
Preparation is over.
Yeah, preparation.
So,
in the operating room, anesthetic drugs, emergency drugs will be kept ready. Then South Pole RA tube, ring adder Elvin tube, cuffed 6 mm internal diameter and lesser size tube will be kept ready. And other airway equipments like flexible LMA, oral airway, nasopharyngeal LMA will be kept ready. And the suction apparatus will be in the working condition. And you can check the anesthesia machine.
okay. Yeah. Then what is your plan of anesthesia like?
Control relation with the cuff RA tube, then with IV injection.
Hello, Avani. Your network has some issue, I believe. I'm not hearing you. Anyway.
Yeah. There is some problem. Some problem is there.
Okay, can we proceed?
Yeah. Avani, now it is okay now.
Plan of anesthesia is
okay. We can proceed like that now. Plan of anesthesia.
Yeah, ma'am. How do you anesthetize this patient? Hello, Avani, can you hear me? Hello.
Something has gone wrong. Something.
I think, madam, can you ask her to switch off the video? Probably the network has got some issue.
No, she's muted. Avani, please unmute and talk.
Okay.
Sir. Okay. Sir.
We were anesthetizing this patient.
Sir. Sir.
Please
Hello.
Go ahead. Please go ahead.
Let's. After the my anesthetic plan is generalized with controlled ventilation with the cuffed RA tube. For the preparing the operating room, child will be shifted inside the operating room. Two stand monitors like a saturation probe, ECG, non-invasive blood pressure, and precordial stethoscope are attached and vitals are recorded. Intravenous access is secured with 20 gauge cannula at the EMLA applied area.
Okay.
I will pre-oxygenate the child with 100% oxygen for 5 minutes. Injection fentanyl 2 microgram per kg is given along with glycopyrrolate 0.008 mg per kg. And prior to injection, I will give injection lignocaine, preservative-free 1.5 mg per kg. And a child will be induced with a propofol 2 to 3 mg per kg. Bag and mask ventilation is started. Injection cisatracurium 0.15 mg per kg is given. After 3 minutes, direct laryngoscopy is done. Intubated with South Pole RA tube with 6 mm internal diameter cuffed tube. And tube will be secured in the midline after confirming the bilateral air entry. Endotracheal tube should be connected to the anesthesia circuit and start intermittent positive pressure ventilation with the nitrous oxide and oxygen in the ratio 2:1 with sevoflurane, with the tidal volume of 160 ml and respiratory rate is 80 minutes. Then baseline end-tidal carbon dioxide and airway pressures are recorded. After that, patient is positioned in the rose position. That is, patient head is extended by placing a pillow under the shoulder. That is, this position allows for a good surgical view and also drain the secretions away from the larynx. After the positioning of the child, air entry should be checked. Then eyes are protected with pads and lubricant eye drops will be put.
Avani, can you just highlight, because I know you have done, you have said most of the things very correctly. Unfortunately, I think some net issues, I will not able to follow most of the things. I just want to highlight for the audience that what will be your primary concern when you set the theater in a case of tonsillectomy? If you can number a few. We are doing a pediatric case. We are doing a case which has got a high chance for bleeding.
Then sharing of airway.
Yeah, essentially we are trying to correlate the goals which you have enlisted before with the OT preparation. OT preparation. So can you just highlight a few of them? I know you have enumerated everything very neatly. Just to highlight a few things which if somebody has missed it out for an academic purpose. So can you just enumerate one or two? Like I'll start. Like the patient, when a patient is being taken, the first thing when you take this patient in, I'll be thinking whether the OT temperature is not too low for this patient. Like I would like to keep the temperature at something around 26 or 25 or something like that. So like that, Madam has already given a clue that you are going to share an airway, so you should have alternate methods of securing airway. And she has also said whether there is you need to have two working suctions with wide bore tubes to aspirate if it in case like that. Anything else like that you would? Yeah.
South pole array tube, 6 millimeter cuffed tube will be there, and Macintosh laryngoscope with appropriate size.
Okay. Okay, can you just give one advantage of South Pole RAE ring Alden Edwin tubes? That's RAE tube. One advantage and one disadvantage.
It's provide a good surgical view.
Good.
To the surgeon.
Yeah.
Disadvantages are suctioning.
So, we are using a South Pole tube, right? We are using a South Pole tube, isn't it?
Yes, sir.
Yes, sir. See, is there any condition which you can highlight whether we use a North Pole tube? Like we can keep the machine, you can keep the tube away when somebody is doing a surgery in the mandible or something like that, isn't it? So that is another condition. Anyway, coming back to South Pole tube, what is the other option? What is the disadvantage of this RAE tubes?
Disadvantage.
Tube will be difficult and the resistance will be high.
Sorry.
Insertion is difficult.
Yeah, insertion. Okay.
Then
resistance will be high.
Then
good.
Then it is difficult to for prolonged ventilation. It is difficult because there's high resistance, and via FOB it cannot be introduced RA tube.
Okay. Okay, you have highlighted important. Yeah, please.
Then appropriate size tube should be selected. Otherwise, endobronchial intubation can occur.
What you said is all right with respect to any tube. Like if I'm supposed to answer this question, I would have been talking the problem with an RAE tube. It is otherwise known as a preformed tube, right? It is a type of preformed tube. So the tube, we may not be able to exactly position the tube. Sometimes it may be too deep, or sometimes if it is too out, if we are not properly sized the tube. So that is one problem. And the biggest problem is one luxury which we are very fond of cannot be enjoyed in an RAE tube. Like if any time, as you said, when you feel resistance and you feel secretions, it will be quite difficult for you to do a suction through a RAE tube, right? That is the biggest problem for anesthesiologists. When you use a routine endotracheal tube, we are very happy that anytime when you feel a resistance, you always do a suction and see whether you're okay. You always do some bag and see whether you are not having an excessive resistance. So all these things may not be very properly judged when we are using an RA tube, let it be south or north pole tube, isn't it? So that is one disadvantage. A proper size assessment, and again suctioning, that is an issue. Advantage you have rightly mentioned. Just to add on a few points, okay? Okay. So can we further proceed, madam?
Yeah.
Yeah.
Then intraoperative period, what else?
At the beginning of the surgery, the surgeon will place a Boyle-Davis mouth gap with the central slit. At that time, endotracheal tube, entitled carbon dioxide, and airway pressure should be monitored, because there is more chance of disconnection, obstruction, or displacement of the endotracheal tube.
Okay.
During the intraoperative period, deep line of anesthesia should be maintained with the sevoflurane, and muscle relaxation will be maintained with the cis-atracurium. For the fluid management, ringer lactate will be given according to the Holiday-Sega formula. In this situation, 240 ml of ringer lactate is given in the first hour.
For this child, okay. Then
for this child. Then a blood loss should be monitored. If it is exceeds more than 10% of the total blood volume, I will give blood transfusion to the child. And for the analgesia purpose, fentanyl supplements is given, and along with that, IV paracetamol 15 mg per kg is given.
Okay, can I interrupt for a moment?
Yeah.
Yes, sir.
See, one thing, how about the monitoring? What are the, I know you have enlisted monitoring in between. So can you just highlight a few important monitors which you will be looking for in this case?
Pre-induction monitoring are ECG.
No, how your monitors are going to help you during the perioperative period.
That's right.
In the perioperative period, entitled carbon dioxide and airway pressure should be monitored.
Okay, very good. So if you want to highlight, I know all the monitoring is important and all ASA standard monitoring has to be kept properly, which you have already done. If you want to highlight like a few monitoring, every monitor is important, but in this case, in a temperature monitoring we have mentioned, isn't it?
Yeah.
So although we may not be routinely doing in at least in
doing.
many of any of our setup, but it is considered to be a significant monitoring, essential monitor. Number two is regarding a precordial stethoscope. You have mentioned already, but I'm not very sure whether you are routinely doing it or not.
Most of the time we are doing it.
Yeah,
we are keeping.
So what do you guess? Because in our center we don't routinely perform it. So what do you get from this preoperative? I mean this precordial stethoscope. What is the inferences? Inferences.
Because it is an airway manipulating surgery. So at the time of positioning of the child and after the placement of the mouth gag, there may be a displacement or disconnection of the tube. So air entry may be reduced. That can be easily identified with the precordial stethoscope.
Okay, so you try to say, yeah, please.
Bronchospasm also you can detect intraoperatively in a susceptible child.
So Avani, you are trying to say that you will resort to precordial stethoscope for assessing the tube position, or will you be more reliably depending on your 5-point auscultation?
Maybe on 5-point auscultation.
Okay, so that is very clear. Of course, you can diagnose the using precordial stethoscope also, not an issue. But is there anything new or anything significant, anything special which you are looking for with a precordial stethoscope?
Tachycardia can be easily.
Tachycardia can be measured. That is true. So I would always love to see the ECG, which shows the heart rate rather than believing my ears. So in that situation, what will be your
if in case of bronchospasm?
Yeah, very good. One is bronchospasm. Number two, the muffling of heart sound is what has been suggested, although I'm not practically much expert in doing that. But for at least from experts, from examiners point of view, I think they will be looking for muffling of heart sound early to is additional sound, adventitious sounds, and to detect early the hypovolemia, all these things you use precordial stethoscope. Anyway, once you are routinely using it, then only we will be able to do that. And in our center, we don't use that. Now, another option is, which will be the third monitor we will be more depending on. Hello?
Hello?
Yeah, Avani?
Dioxide.
ETCO2, very good. Madam has already highlighted the role of ETCO2. So can you tell how ETCO2 will help us in this?
In case of
In a case of tonsillectomy. Yeah, very good. First one is tube positioning. After intubation, it gives you a continuous ETCO2 trace, which tell you that the tube is in position, number one. Number two is?
In case of obstruction, there may be a
yeah, very good. Yeah, in case of obstruction, and in this case, when do you feel, what are the situations where you anticipate an obstruction in a case of tonsillectomy? Adenotonsillectomy.
At the placement of mouth gag.
Very good. So in placement of a mouth gag is one point where you will be concentrating more on ETCO2. Every time you look it, but this time I'll be specially looking at it at least to find out whether there is any reduction in the ETCO2 or there is a displacement, isn't it? But you cannot entirely depend upon, you will have to go with the auscultation even after the positioning. That has to be highlighted. Clear? And one more point is, see, regarding this ETCO2, you have already mentioned these points, and presence of secretion is also another thing which will make a significant change in the ETCO2. That is also important. And can you tell me, yeah, bronchospasm. Yeah, can one more option about one more monitor which I will depend upon after placement of the BD. Boyle-Davis gag.
Airway pressures.
Very good. Excellent. That's an answer which I will be keenly looking at in this case, because after the positioning, we will be looking the auscultation for bilateral air entry. You will be looking for the airway pressure, which has not changed significantly, because as you rightly mentioned, there is a split, and in between the split, you will have to keep the tube in order to protect our tube from kinking, isn't it?
Yes.
So that, but many centers, if you, and what type of circuit do you prefer in this case?
It's 8-year-old child, so anesthetic circle system can be connected to the anesthesia ventilator by a circle system.
Avani, can you specify you are looking at the age of the patient or weight of the patient?
Weight.
So what is the weight of this patient? Which
20 kg.
So you are your primary choice is to go with a circle system for a 20 kg patient, right? Anyway, if you have that option, it's well and good. You'll be looking at the airway pressure. But in centers where you don't have this for universal benefit, we will be always looking at, if the patient child is smaller, we will be looking at the back pressure or the compliance or the back. That will be very useful in such situations. Very good. You have brought this point very neatly. Anyway, one more point I would like to add is I'll always look. It is commonly bypassed, or it is commonly overlooked, that monitoring blood pressure in a pediatric patient, which has to be specifically looked in. Although most of the tonsillectomies doesn't take more than 20 to 30 minutes, sometimes even 40 minutes, depending upon your situation. It has to be specifically highlight that this patient blood pressure has to be monitored with an appropriate cuff, because it is going to help you intraoperatively to get a standard value. It will help you to find out the value post-operatively if this patient is going to come to you for any complication, say post-operative bleeding or post-tonsillectomy bleeding. It is always better to have a baseline blood pressure. So please make a point that you monitor that also. Okay. So that has been most of the time highlighted in pediatric cases. Kindly note a point on that. Okay. Do you really catheterize these patients?
Usually not routinely catheterize.
Never.
Okay. Okay. Thank you for that information. So can we proceed? So you were talking about keeping the Boyle-Davis gag, right? Avani, you were talking about keeping Boyle-Davis gag.
Yes, sir.
Okay.
Then perioperative fluid therapy also over. That part also she has.
Okay. Okay, madam.
Coming to the end of the surgery, injection ondansetron 0.1 mg per kg is given to reduce postoperative nausea and vomiting. Injection dexamethasone 0.15 mg per kg is given to reduce the postoperative nausea, vomiting, airway edema, and it also provides good analgesia. At the time of the removal of mouth gap, there is a high chance of accidental extubation. So, anesthetists should be vigilant. And at the end of the surgery, thorough suctioning will be given under direct visualization. Suctioning is also given in the head flexed position to drain all the secretions in the nasopharynx. Gentle suctioning of the nose is also given. After suctioning, when spontaneous attempts are present, child is reversed with injection neostigmine 0.05 mg per kg and glycopyrrolate 0.008 mg per kg, and child is extubated in the left lateral position. After giving suction, 100% of oxygen is given via simple face mask after extubation. And in the postoperative period, child should be kept in tonsil position, that is the recovery position, left lateral position with the head low to allow the drainage of secretions away from the lab. And postoperative analgesia is continued with injection paracetamol 15 mg per kg IV 6 hourly.
Hello.
Hello, madam, please proceed.
Hello, sir.
Hello, Avni. Then, what is your opinion regarding nasotracheal tube and also regarding a supraglottic airway device in a case of tonsillectomy? Especially when the child is coming for tonsillectomy, they may ask for a. It was a practice one. So, what is your opinion regarding use of a nasotracheal tube and also the role of a supraglottic airway device? Actually, two
nasal
questions.
intubation is less preferred because
why it is less preferred?
Nasal intubation is less preferred because it causes epistasis and introduction of infection to the lower airways, and it also causes nasopharyngeal tear. But in olden days, if there is no adenoid hypertrophy and only tonsillectomy is done, nasal intubation is done prior. But usually nasal intubation is not preferred. Then supraglottic airway devices is also less preferred in case of adenotonsillectomy because with that poor view for the surgeon, and it is not a definitive airway. So there is a more chance of aspiration, and there's a possibility of dislodgement of the tube during the surgical manipulation.
The requirement for a nasal tracheal tube, that is almost met by using a RAE tube, South Pole tube. Then that is one reason. So we don't have to use a nasal tracheal tube. Then these problems of nasotracheal intubation are there. Then regarding supraglottic airway device, why it is preferred? What is the point in favor of using supraglottic airway device like flexible LMA? Only thing is
muscle
that
relaxation is not required for insertion, and
yes,
smooth
neuromuscular
emergence
blocking
from the
drugs we can avoid. Then okay, recovery part.
Smooth emergence from the surgery.
Okay. Okay, continue with the reversal extubation.
After suctioning, child will be reversed with the injection neostigmine 0.05 mg per kg and glycopyrrolate 0.08 mg per kg. Child should be extubated in the left lateral position after giving the suction. And the child should be kept in the recovery position, that is tonsil position.
What is the why you prefer this tonsil position?
Because the drainage sections away from the larynx, so there is risk of aspiration.
Okay. Again, that audibility problem is there.
Hello.
Hello, ma'am.
Hello.
Hello, sir.
Avani, you are talking about nasal intubation, right?
Yeah.
Yeah, that point
Actually,
has been cleared, no, madam?
yeah, clear.
Okay, okay. We don't usually prefer nasal intubation in most of the cases, right?
Yeah.
Because it is an older aspect where if at all you want to do, you do in adult, little older children, not in younger children, because of adenoidectomy may be done by ourselves itself. So that is one other issue. Another thing what I heard is about LMA regarding or other alternative methods regarding
Flexible LMA.
Flexible LMA. The trend is actually coming up to use flexible LMA for many reasons. Number one, is that we don't have to extubate the patient in a deeper plane. The patient can be taken out smoothly. The stretching and straining can be can be easily done if you have an LMA. And what they suggest is, although we don't practice it routinely, it is only it is a newer trend. That's what it has been defined. We actually don't deflate it completely. We partially deflate it and take it out so that we swipe out the blood secretions and the blood from the surgical field. And if I'm not wrong, Avani was mentioning about the spontaneous ventilation. One of the advantage of LMA was to avoid muscle paralysis, isn't it?
Yeah.
But actually, unfortunately, I may have to differ with that because spontaneous ventilation is not a preferred technique in tonsillectomy.
Not preferred.
Yeah, not
that also is there. That is there.
Yeah,
the advantages.
Yeah, so it is so it is not a preferred technique
not
in
a preferred technique.
because then in such cases we'll have to use larger volume of volatile agents which can produce some emergence reactions and deliriums. So that will not be very good in these cases. So one point,
particular advantage noted.
Yeah,
no particular advantage.
And one more point which is regarding the current use of dexmedetomidine. So that is something which you can add upon because dexmedetomidine has been constantly being used in almost every purpose, and we can use in maintenance as well because it will prevent this emergence reaction or emergence deliriums as well with volatile agents.
Especially with the sevoflurane.
Sevo and iso things like that.
If it is not contraindicated, we can go for isoflurane.
Yeah.
Then that will prevent emergence.
That's right. So that is a few points which we thought we will highlight for the interest of the group. Now there was few questions on the this one whether we can use Jackson Reese. Definitely we can use Jackson Reese in a patient with less than 20 years. Most of the centers we use that only. We don't have the classic closed circuit as Avani has described.
Ventilator.
Yeah, ventilator. So Jackson Reese is an absolute good answer for this question.
Then another thing is whether why cisatracurium or a non-depolarizing agent rather than succinylcholine.
Yeah.
Avani, can you say something about that? Why you prefer cisatrac rather than why you wanted to avoid succinylcholine? Or when will you go for succinylcholine? Hello?
Choline is preferred in case of a difficult airway is anticipated, but the disadvantages are it causes arrhythmia, masseter spasm. So it is only preferred in case of difficult airway. Cisatracurium, it causes less histamine release, so there is a less chance of bronchospasm. And
okay.
Can Vecronium be tried in this case?
So usually short during if any difficult airway occurs, so Vecronium is less preferred.
Okay. There can be institutional preference variation anyway. What is institution practice is the best answer.
Recovery profile also better than is quick recovery with the cisatracurium.
That's right. There was one question regarding the use of holiday scoring, holiday the administration of holiday agar formula. as they have mentioned, it is not basically we don't depend upon holiday agar formula right now because they are telling that it is not scientifically right nowadays. But anyway, there is this. Yeah, madam, you want
We are going by that. Still, we are giving fluids accordingly only because this is a that much loss we are.
Easy. Yeah, it is very easy to calculate and administer, and that is what we are being practicing.
So we avoid giving hypotonic solutions. We give only ringer lactate. But how much to give? We go by holiday agar only.
Yeah, there at this juncture, I just want to add a few points regarding what a point called superhydration in tonsillectomy.
Superhydration.
That may reduce post-operative nausea and vomiting.
That's right. Okay. Yeah. So you have extubated the patient, and we are reaching to the tail end. Can we discuss post-tonsillectomy bleed? What are the complications? Can you enumerate a few?
Emergency agitation, post-operative nausea and vomiting, post-operative pain, laryngeal edema, laryngeal spasm, aspiration, recurrent respiratory infection, post-tonsillectomy bleeding.
Okay, very good. Madam, can we discuss post-tonsillectomy bleed?
Yeah. Okay.
Yeah. Have any clinical condition, clinical feature? How do you diagnose? How do you manage?
The hemodynamic, usually child may swallow the blood. So blood loss cannot be calculated by looking the blood loss. So hemodynamic parameters are used. There may be tachycardia due to anxiety and catecholamine release secondary to maintain the cardiac output. There may be tachypnea, delayed capillary refill that is more than 2 seconds, decreased urine output, hypotension and altered sensoria, bradycardia can occur in the late signs. Then core to skin temperature difference more than 2 degrees Celsius are the clinical signs. Along with the assessment of the child, fluid resuscitation should be started as early as possible. Then IV access should be secured. Cris load 20 ml per kg is given and reassess the child. Cris load can be given up to 40 to 60 ml per kg and oxygenation can be given via simple face mask or nasal prongs, but usually child will not tolerate the face mask. And look for airway difficulties like stridors, intercostal retraction. And time since the last injection of food should be noted. Examine the previous chart, analgesics used, endotracheal tube size or a difficult airway, hemoglobin, packed cell volume, coagulation variable will be set. Blood and blood products should be kept ready. Along with the patient preparation, in the operating room, 2 suction device with whiteboard tubing that should be turned out, laryngoscope with the correct size, endotracheal tube of same size and lesser diameter, wide nasogastric tube, then Magel forceps, video laryngoscope with Macintosh blade, other airway equipments like supraglottic airway devices and airway bougie should be kept ready.
That is, you have raised the OT.
Manage. Main anesthetic concerns are child is a hypotensive maybe in the hypovolemic shock, and there is a risk of pulmonary aspiration because of the regurgitation of the swallowed blood or the post-operative oral intake. So consider as full stomach. And there may be potential for difficult intubation because bleeding can obscure the view and edema from the previous surgery. Then it is a case of second general anesthesia and the risk of hypothermia due to the large oleum transfusion. Then anesthetic plan is IV with rapid sequence injection. I will pre-oxygenate child and you should prefer, if hemodynamically unstable, prefer injection ketamine 2 mg per kg and the preferred muscle relaxant is succinylcholine 2 mg per kg and intubated with a cuffed endotracheal tube. Then during the intraoperative period, blood loss should be calculated and fluid resuscitation is continued with the crystalloids and colloids and blood product will be given. And to prevent hypothermia, warm blankets and warm fluids will be given. And at the end of the surgery, nasogastric tube under vision is introduced and aspirate the swallowed food.
Okay, so during regarding your plan was for an intravenous injection. So why an intravenous injection is preferred? And then what is the problem? Why hypothermia? Why you are fearful about hypothermia?
In case of IV, with rapid sequence injection, supine position with a cricoid pressure that will reduces the risk of aspiration, and it is less stressful for the child compared to the inhalation injection.
Then,
but in case of
muscle relaxant, succinylcholine, that will give an ideal condition for intubation. But what is the problem?
Pre-oxygenation will be impossible due to rapid sequence injection,
and denitrogenation may not be very much effective. Then, okay.
If a difficult intubation occurs, the child may go for hypoxia.
Because this is a hypovolemic child, and we are giving succinylcholine, which can precipitate arrhythmia also. So that can become dangerous. Cardiovascular collapse can occur at that point. Then what is the other option for induction for this in this scenario? What is the other option for induction?
In the head down.
Yeah. Inhalational induction in the head down.
With the in the lateral position and head down position.
What are the
but
pros
it is
and
difficult
cons?
to in the anxious child.
Okay.
It's difficult to carry out in an anxious child, and deep anesthesia induced inadvertently because child is recovering from the previous anesthesia, and due to the hypotension, the risk of cardiovascular collapse may occur, and there's high risk of aspiration, and laryngoscopy in lateral position is
difficult. Okay. Then for this
advantages
case,
of inhalational injection are oxygenation is well maintained during the spontaneous ventilation.
Okay. Then some are very much familiar with the technique.
Drain the blood
secretions. Okay. Then here the choice for what is the tube for choice? Is it an RAE tube? Will you go for an RAE South Polar tube? Here conventional endotracheal tube is the choice.
Normal cuff tube.
Okay. Then what about the then you have to keep ready the supraglottic devices you had was there, isn't it? Hello?
Hello?
Already missing. Okay, so that is over. No.
Yeah.
Avani, please unmute and talk. Avani.
No, are we towards the end, or do we have some more time, or how is it?
Yeah, you can discuss. You have any questions, you can discuss. You can complete the session. No problem.
So actually, the final aspect which we will discuss is there are a few complications which she has highlighted, but unfortunately she is missing in between because of the net issue. So when a patient comes with post-tonsillectomy bleed, the biggest issue is that we will not be able to assess the depth or the breadth of the situation properly because you hardly see the blood because it has been swallowed. So when in a post-operative patient, towards the end of the surgery, it is always a good practice from anesthesia point of view to have a look of the tonsillar bed for the bleeding, so that you don't have to face the same patient again after some time. So make sure that
then there are some predictors for bleeding also.
That's right.
Like the technique of surgery, older child, male child, then hot technique versus the cold technique. The age-old cold technique where they use the blunt dissection and just ties and packs, less bleeding and less pain in the posture. Then when diathermy for the dissection and hemostasis, more bleeding and more pain.
That is true.
So the technique wise, we can anticipate. In these conditions, we can anticipate.
Okay. Yeah. So in the post-operative recovery room, when you have to primarily classify this as a primary, secondary, or reactionary hemorrhage. and that we'll have to find out depending upon the time, and then see whether the patient has got increased incidence of swallowing. If the patient is you have a whole spectrum of patient, right from a patient who has got a simple ooze with or to a massive unconscious patient with a massive bleeding which are swallowed inside. So you can get any spectrum of post-tonsillectomy bleed which we'll have to identify. So if in a post-operative recovery room, if you see the patient engulfing or frequently swallowing, you think whether the patient is not aspirating. So it is always a good practice to put them in the tonsillar position and ask your surgical colleague to have a look on the bleeding. Otherwise, you are planning to face the problems again. So that is one point. Again, there is always another point. As I mentioned already, the blood pressure checking is another clue which will tell you what kind of hypotension you are going to face. And number three is presence of hypothermia, the coagulability associated with that. And the next option is regarding the capillary refill, which will always tell you how much is the hypotension, because you may not be able to assess the.
It is an indication of perfusion, organ perfusion, skin perfusion, like.
Yeah, ma'am. So those things.
Catheterization and urine output measurement, that also is important. Less than 1 ml for older and less than 2 ml per kg for infants. That is the.
So this is when you see the patient for the first time in the recovery, and then once you see the anesthetic management start right from the moment you see the patient, because the first thing you will have to do is to if it is a small bleed, it's always better to put an oxymetazoline drip on the same nose where you anticipate there is a bleeding. So that will trickle down. You can use a liberal amount of oxymetazoline and keep it into that position so that it trickle and go down to the bed of the tonsillar fossa to produce some amount of vasoconstriction. There can be also literature which says that you can always ask the patient if he is conscious to use cold saline. Cold saline and or small packs into the fossa if the patient can tolerate. These are all methods you can contribute to reduce incidence of bleeding, the quantum of bleeding. And post-operatively, as Madam has mentioned, when you take up the patient, it is always better to have an additional IV line blood arranged, and always better to have a smaller tube than the previous tube. And you anticipate you are going to have a subcricoid edema. Or a smaller, narrower airway, a more reactive airway. There is a residual of neuromuscular effect, residual of the opioid which you have already administered. So all this can be an issue in this patient. And top of that, you are going to have a rapid sequence induction because you can aspirate. So one comment is regarding the nasogastric tube, which when to keep. It is always after the intubation, you will need to put the nasogastric tube.
It is after achieving the hemostasis.
Yeah.
After,
so it is never before. So the common concern is you think that something is aspirated, you maybe tend to put an nasogastric tube to take out the gastric content, which should never be done. It is always after.
Ideal to have a point of care hemoglobin, hematocrit, coagulation is ideal to have.
Okay, I think we are almost running short of time. There are a few more.
Avani
has been provided distinction and she has gone for celebration. And,
I'm here.
Oh, here. Okay. So there can be few points which you need to highlight regarding the laryngospasm,
laryngeal edema,
post tonsillectomy dysphagia. Grissel syndrome. These are all symptoms which these are all complications which you can have in tonsillectomy patients, which we will discuss in some other time if time permits. So can we grant her a distinction, madam? From an external point of view, I think she has done an excellent job. Thank you for the opportunity to the organizers. And I can see great teachers and examiners in the group, so I think they can make their comments and can suggest modifications.
So we missed this laryngeal edema and spasm. That is the these are the 2 points we missed. Hello.
Yeah, you are audible.
Ashish is telling we can wind up. That's okay, no?
External examiner is out. Now it's internal turn.
No, madam, if you now if you want, you can take the opinions from other seniors and our examiners.
Yeah.
I allow the participants to unmute themselves. So if they want, they can unmute and talk.
Okay.
So we have senior faculties in the group. Dr. KK Mubarak is there. Dr. Gurudatt was there. You can ask their comments. And let me make some comment. Dr. Ashish has said. Dr. Anand Bangera is there. He's the examiner in the next session. In fact, he has written a beautiful review about tonsillectomy in IJ. I think he has written.
Actually, in 79J, it is there.
Yeah. So let me make one comment. Dr. Ashish has mentioned about nylon reinforced LMA. Flexible LMA. So it's a technique which is widely used.
Practiced.
Yeah, practiced. May not be in our settings, but it is used. The tonsillectomy is quite doable. But there were concerns about Jacobs-Creutzfeldt's disease spreading because of repeated use of
prion disease.
Prion disease. That's why that's a real concern. So it was.
On the LMA and supraglottic devices, we can do ETO. That will be safe, no?
Yeah, even with the ETO, even with the ETO, there were concerns about the prion body contamination.
So
that was one concern.
Then that repeat use or reuse, how much? How many times you can reuse? Any comments like that?
No.
Any suggestion?
No, what I say is that it is quite doable with LMA, but the concern is that the prion body contamination.
Okay.
And another comment is that it is now widely practiced as a daycare procedure.
But daycare,
but you have to select your patients. Like
yes, we have to be careful while selecting. Like they should have a private transport facility. You should report within 1 hour if there is a bleeding or a feeding problem, pain, severe pain, and all. So,
and the severe OSA patients we won't select for daycare patients. Any history of bleeding diseases like that. But most of our tonsillectomies are done, and less than 3 years we generally don't do.
Yeah, less than 3 years OSA and this other features.
Yeah.
If you anticipate bleeding and all.
Yeah, that's all. We'll ask comments from Professor Mubarak. Mubarak sir is there. And
good evening, Dr. Rajesh.
Good evening, sir.
Ashish, it was a lengthy discussion over the tonsils. But for exam point of view, tonsil is given as a short case, and the maximum time of duration of discussion is only 15 minutes or 20 minutes.
So sir, you are telling was this too much, sir? Like that it is?
No. For discussion
but the thing is, any question will be asked. No, they should be knowing also.
For teaching purpose, we should take more time. But
that is why.
That's true. But the candidates should know that all these things has to be done in 15 to 20 minutes. And 1 or 2 comments I would like to tell is her presentation was also like a long case discussion. You should not try. I think till date, nowhere a tonsil has been given as a long case. So that presentation was a type of a long case presentation. So a short case, a brief
just a summary and positive findings was necessary.
That would have been better. Then one thing regarding post-op, and I am a person who has underwent a tonsillectomy when I was an MBBS student. And the post-operative pain is one of the severe pain during after tonsillectomy. So something regarding post-operative pain relief after tonsillectomy would have been highlighted. One thing.
But literature says it is only mild to moderate pain, and nowadays local anesthesia is less recommended. Like local
I have experienced.
Okay, sir. Okay.
Yeah. Okay, I have personally experienced the post-tonsillectomy bleeding, and while and tears used to come from my eyes while attempting swallowing after in the post-tonsillectomy period. Then regarding one or two post-tonsillectomy, post-operative pain is an important thing. Then 1 or 2 things I would like to add is that, for example, that at pre-medication she has told only midazolam. I think and glycopyrrolate or anticholinergic was she has given intraoperative period. I would prefer to have given it earlier because it's an oral surgery. In the pre-medication I would have suggested
along with pre-medication. That should be a part of pre-medication. Okay,
it should be. She has given only midazolam. And and then another thing, the ondansetron she has given post-operative after the surgery, because that could have been given earlier. Antiemetics is a necessity in post-operative bleeding, so it is better to have an antiemetic given a little prior to prevent the post-operative.
In the literature, that also is given towards the end of surgery, like.
But
that's
and
why.
tonsillectomy, the surgeons are
in practice
different.
we used to give it early, sir. In practice we give it early.
There are surgeons who does tonsillectomy in 5 minutes, and there are surgeons who does tonsillectomy in 2 hours. Okay. So towards end of surgery, it makes a lot of difference. So you should be familiar with the surgeon's experience, expertise, and then another thing, the use of ETCO2 could have been highlighted a little more, because airway is the most important problem in tonsillectomy surgery. So just use of this ETCO2 should have been highlighted for confirmation of the endotracheal tube, for even after applying boils, gag applying and all, it may give an obstructive pattern, accidental extubation. Sometimes some surgeons may require the tube to be changed to either sides, right and left. So it has already been discussed. So in the exam point, the candidates should have been highlighted these things regarding the shared air, the anticholinergic use, shared airway, use of ETCO2. These are almost everything has been done and so far, and so it was a good discussion, and it was nice to be more than 1 hour discussion. It was tonsillectomy. So it was good to have with Ashish, my own colleague, and it was
I should give distinction to her, sir.
Yeah. She did very well. No, just since I was asked about some comments, I was telling the few comments. Okay, thank you.
Thank you, sir. We will ask comments from Dr. Anand Bangera if he's still there, because he has written a review about beautiful review about the topic.
It was a very good discussion. Each and every aspect of the anesthetic management is discussed.
Yeah, thank you.
There are a lot of controversies in anesthetic management of adenotonsillectomy, including doing it as a daycare surgery and use of LME, all those things. And as I told, all these controversies I have discussed in my article, a review article about IJ. Everything is covered. Yes, it is a very good discussion. I don't think I have any further point to be discussed. Thank you very much.
Thank you, sir.
Thank you. We'll see you next week, Dr. Anand Bangera.
Yeah. Okay.
Sir, if the internal examiner allow, can I have a word?
Sure. Dr. Shanti will allow.
Madam, actually, most of the points has been taken from the SIJ only.
Sir's article only. That was the base of this
discussion, and in fact, there were no other articles found on the.
So complete. It was so complete.
Research. So we are actually really privileged to have the person to have it in the group. And actually, Mubarak sir has highlighted the point of analgesia, which we have deliberately missed out, not because of the unimportance, it was just because of lack of time. So, so that is actually just to highlight a few. One, we have about the dexmedetomidine, we have already discussed. We have said that intraoperatively there are surgeons who give glossopharyngeal nerve block in the palatoglossal fold, just 0.5 centimeters, which provide excellent analgesia. After the tonsil, they just keep the pack with lignocaine or bupivacaine and ropivacaine and leave it some time. That is also another.
That can cause postoperative respiratory problems also, aspiration because of the reflex suppression. That can be that. That also is there. So
reflex suppression and aspiration has been defined, as Madam has rightly pointed out. It is defined as more towards the lignocaine spray which they use. So that is definitely has produced silent
lignocaine spray can precipitate spasm also.
So that is also one of the thing which we have discussed. Along with that, if it is smaller children, we can use the rectal paracetamol or rectal suppository, which we can discuss. Regarding the use of opioid, regarding the use of NSAID is controversial, but they have highlighted that ketorolac cannot be used.
Cannot be used.
Cannot be used. That is something point which you need to
Then
understand.
child with an reactive airway disease also we can't use NSAID.
NSAID. So probably it is finally coming out to paracetamol,
Paracetamol.
and finally a whole bout of ice cream at the end of the surgery.
Yeah, that is
So
what
I think
sir said.
Mubarak sir was unfortunate to receive one.
The correct feedback is from sir only.
That was the worst time where because
sir is a
you can't take the ice cream because of your severe pain.
You are diabetic.
I had tried ice cream during my post-operative period of post-operative. But tears will come out of the eyes because
actually because my only experience with tonsillectomy is both of my children got tonsillectomy done, and that is the only time where my family has taken so much of quintals of ice cream at a time. So
family can take, but the
that is
children,
just for a lighter note, sir. Thank you all for the excellent.
One thing that I can add is I don't know whether it is discussed. After tonsillectomy, when you are doing suctioning, you have to put a laryngoscope, you have to visualize and take out all the clots. Because sometimes there may be clots around the endotracheal tube.
That is called corona's
clot.
And you should not do a blind suctioning, because if you do it blind, you may be suctioning over the tonsillar fossa. Sometimes you may even dislodge the ligatures that they have put. But if they were done some cauterization, so you may dislodge the clots, so it may start bleeding. So you are not supposed to suction over the tonsillar fossa at all. So I think in this any tonsillectomy cases, you have to visualize through the laryngoscope and do a good suctioning.
Yeah, that's an excellent point.
That is what I just wanted to add.
And another point, Dr. Ashish, regarding pre-medication, we used to give dexmedetomidine intranasal.
Dexmedetomidine oral not available, only intranasal is available.
Yeah, we put it through the insulin needle.
Okay.
We take it in the insulin needle, and we have now 50 microgram preparation also.
Neon.
So that gives
clonidine, dexmedetomidine, analgesic property also. So better compared
clonidine,
to
I haven't used for this age group, but dexmedetomidine is our routine for pre-medication for tonsillectomy. And Gurudat sir has left.
I think the examiner's time has been exceeded. Our passionate is waiting.
So we'll hand over to Dr.
Ashish. Dr. Ashish is a very good examiner. Even though he is smiling, the questions are not so easy.
No. It's all. It's all from IJ.
Yeah, the difficult questions also he asked and smiled and asked in a nice way. I like that. And on the end of the show, he awarded 80% distinction to the candidate. And since he told we should award a certificate to candidate, so I am just sharing the certificate and request our national president-elect, Dr. Venkatagiri, to present this certificate to our candidate, Dr. Avani.
Sir.
Giri sir, please.
Okay, thank you, Sajid. Binil, I'm happy to participate at the end of the. I was there in the beginning, never at the end, because I had some religious program at home. I'm not able to. So I'm in the attire of the puja at home. Anyway, thank you. And I heard that last minute it went on very well, and examiner was tough but a smiling face, and he was leading. That is good. That will give you confidence in the student. If you ask that you don't know this, that, and all, then they will lose confidence. But that's good that though it is tough, extract the answers from the students or lead them to the how to do that, because everybody can't know everything. So you have to lead and get the answers. Thank you very much. I'm happy to present the certificate to the candidates. Thank you.
Thank you, sir.
So, all the best in the exams. Do better than this in the exams.
Thank you, sir.
Should be 100%.
Thank you, sir. I'll just read out the names, sir. She was Avani Sanjeevan from Government Medical College, Kottayam.
ISA member, and A4159A is the number. Okay. Only ISA members can participate, others cannot. They will not have this opportunity.
Okay. Thank you, sir. Thank you, Avani. And now we will move on to our president, Nasser, sir, please.
Yeah, it was a really a very nice and elaborate session covering all the aspects of this topic. Thank you, speakers. Thank you, Dr. Avani. I thank you all for the excellent participation and very elaborate discussion. Thank you. Thank you, Ben. Okay, over to Birin for just by winding up the session and expressing your thanks.
Anand Bangar also there. Next week exam.
You,
I think he's the next.
I just want to yeah.
Dr. Shanti happens to be my
remind that Anesthesia TV team with Mr.
Rahul Chobe.
Okay. Anesthesia TV team, Mr. Chobe and Sham, Rahul Chobe and Sham, they did a wonderful job. They streamlined live this program. And even last program also, there's streamlined and around 2,000, around 4,000 participants were viewing the show. And even today, we don't know how many were watching. By tomorrow, they will be informing us. And thank you, the Anesthesia TV team, for the live streaming. And I thank today's faculties, Dr. Madhusudan Upadhyaya, former HOD and of KMC Manipal, Department of Anesthesiology, KMC Manipal. And Dr. Sanish TJ, senior, our own member, senior consultant, Anantapuri Hospital, Trivandrum, for their excellent presentations on uptake of distribution of inhalation agents and inhalation agents. So they have covered all the area of inhalational agents today for the PGs, and it was a wonderful presentation from them, both the Guru and the Shishya. And I extend my sincere thanks to Dr. Shanti KS, Additional Professor and Head of the Department, Government Medical College, Kottayam, and Dr. Ashish Karthik, my friend, Associate Professor from Trichur Medical College, for conducting this wonderful examination. And Dr. Avani Sanjeevan from Government Medical College, Kottayam, performed very well. And thank you, Avani. Thank you, examiners, for this wonderful show. I extend my sincere thanks to our President-elect, Dr. Venkatagiri, and our State President, Dr. E.K. Abdul Nasser, for helping me to organize this program. I extend my sincere thanks to Dr. Vijish Venugopal, our past Scientific Committee Coordinator, Professor and HOD of KMCT Medical College, Mukkam, and Dr. Rajesh MC, Senior Consultant, Baby Memorial Hospital, and our Scientific Committee Coordinator of ISA Kerala State Chapter, for organizing the entire show. Thank you for all the participants who attended today's show. We will be showing the recorded version of today's program in YouTube. Please do subscribe ISA Kerala YouTube channel and watch the programs. And thank you and good night. And I wish all the members a Happy New Year and belated wishes of Christmas. Merry Christmas and Happy New Year. Thank you and good night.
Good night. Good night.
Thank you. Thank you.
Madam. Thank you.
Happy New Year. And Dr. Shanti, has she left?
No.
She